Bismillah ar-Rahman ar-Rahim. It's a great honor for me to announce for the second day in Specialty Day, which is the Spine Specialty Day. Thank you so much for my dear friend, Professor Muhammad Khattab, the president of the Egyptian Spine Association, for his great help and making this day a cooperation and collaboration between the Egyptian Orthopedic Association and the Egyptian Spine Association. Thank you so much, sir, for your great effort in the preparation of such a great day with great eminent professors from all around the world. Actually, we have 5 speakers. First speaker will be Professor Christoph Saipi from Germany. The second will be Professor Abhay Nini from India. The third will be Professor Hassan Salhin from Germany. The fourth will be Professor Hamdan Abdurrahman from Germany. And the last one will be Professor Ali Abul Ma'adawi from Suez Canal from Egypt. Usually, we used to have many attendees from Egypt and from all over the world, more than 1,000 attendees in all specialty day. So I hope this day will be the same as the whole days we have done before. We have been making the online teaching since now more than 5 years. With the help of our great professors and our eminent stars, the speakers from all over the world, we achieved this big achievement. Thank you so much, Professor Khattab, and hoping for a great, successful day with your help, sir. Please, sir.
Thank you, Dr. Al-Ashab, for your nice introduction. And let us start this nice specialty day with Professor Dr. Christoph Ziba. Christoph Ziba is the head of spine department at Schön Klinik, Harlachen, Munich, Germany. He is one of the pioneers in endoscopic spine surgery. And today he will give us a talk covering the spinal canal stenosis. Christoph, happy to have you between us.
Thank you very much, Mohammed. It's nice to be there. I wish I could join in person, but we'll have to do it online. So let me share my screen. And please let me know if you can all see my screen.
Yes, sir.
Okay, that's great. So I have been asked to talk about lumbar spinal stenosis from A to Z. Now that is a very wide topic. And I will really start from A and we will go all the way to Z. So I will start about the pathophysiology, how does spinal stenosis develop, the clinical symptomatology, and then in the end, and that's a very big field, is what are we actually going to do with our patients that have spinal stenosis, conservative therapy, surgical therapy. So there are a lot of options. So plenty to talk about, but I was told that I have 40 minutes. So let's get started. First of all, pathophysiology of lumbar spinal stenosis may sound boring in the beginning, but actually the more you dig into it, it's very, very interesting. Because there are factors of anatomy, cell biology, biochemistry, disc metabolism, and so on, and genetics even. So it's a very, very wide field, and it's interesting to also dive into these topics that we don't deal with every day. So first of all, we have to take a look at the smallest unit, the functional spinal unit of the spine, so the vertebral bodies. The 2 adjacent vertebral bodies, the disc in between, and then obviously the facet joints in the back. So we have a 3-joint complex, the facet joints in the back and the disc in front, and they harmoniously move with each other in a healthy situation. And you can see that here in this nice animation, and actually the way that it works is highly complex. For many years, we tried to imitate this natural motion of a disc with artificial disc replacement or with other kinds of technologies, but we cannot mimic this complex behavior. Look at this, from the disc in the front, the facet joints in the back. So the movement there is very, very delicate and very harmonious between the disc and the facet joints, what you saw in the previous animation. If we look at the structure of the disc, this is a very nice publication that has been published on this. We can see the outside annulus with reversed fibers, and that is a very strong, it has very strong tensile properties. And then if you look in the inside of the disc, we have a very high proteoglycan content, so a lot of water. And what this means is that in a healthy disc, as you can see here on the right side, on the top, in a healthy disc, the load distribution over the entire disc and the annulus is very homogeneous. However, when the disc starts to degenerate, and this is what you can see here in this bottom image, then the stress in the disc is more and more shifted outside to the annulus. So in degenerated disc, much more loads on the annulus than it should be. So what else is there? The disc metabolism. The disc metabolism is extremely slow. And this means that once there is a degeneration, once a degeneration has occurred, there is very limited possibility of healing. So if we have a bone fracture, you fix the fracture, and after some weeks, it's basically like new. However, with the disc healing, we don't have a situation. It's much more like a meniscus, for example, like cartilage. There's very limited ability, sorry for that, very limited ability to recover from any mechanical injury. And that's a problem. So if we have a disc degeneration, what we can tell the patient is it's probably going to stay the way that it is, but maybe it's also going to deteriorate. At what speed, we don't know. So let's say we have disc degeneration, what happens? And this is what here Robert Moore from Australia, what they established and examined in a very nice study. So they basically created standardized settings of disc degeneration. So basically what they did is they created a stab incision into the disc and then examined what happened. And you can see that when you create an incision into the disc, that after a while the disc will start to degenerate after the standardized incision. And with a long delay, then later on, we will see the first degenerative changes of the facet joints also. Now that's very interesting. The first interesting thing is that when you stab into the disc, that this causes disc degeneration. So I remember in the old days when I started, we kind of made a stab incision into the disc in order for X-ray level localization to see if we operate the right disc. But you can see here, and that's why we don't do this anymore nowadays, and I assume you do the same thing, we don't stab into the disc, okay? Because if you do that, it's basically like puncturing a tire of a car or of a bicycle, and the air will go out, and this is exactly what happens to the disc in the spine. And it's interesting that once we have a disc degeneration, we can see after a delay that there is also degenerative change to the facet joints. And this is what these authors, Fujiwara, what they examined. So they correlated the degree of disc degeneration and looked what impact and what correlation is there with the degree of facet joint degeneration. And then we can see that there is a correlation. So with a slight delay, again, similar to what Robert Moore found. So if we look at now our functional spinal unit, we have the discs. They start to degenerate. After a while, the facet joints will start to degenerate. But what is the next important structure in spinal stenosis? It's the yellow ligament. So what happens to the yellow ligament in this entire process? So you can see here, I played a little bit on an animation thing and I came up with this animation, but it shows you quite nicely how the yellow ligament basically covers the spinal canal almost like a tent. And any hypertrophy in the yellow ligament ultimately will have a compressive effect on the neural structures. So this is what this fantastic study investigated in a clinical study, and then they also had a part 2, histological, biomechanical evaluation, and so on. And I'll show you the results. So first of all, the authors from the study found the mean thickness of the yellow ligament is between 2 and 4 millimeters. It's the thickest at the level L4-5, and this thickness increases with age at all levels, but the increase in thickness is most pronounced at the levels L3-4 and L4-5. Sorry, and we know that these two levels are the ones that are most commonly affected by spinal stenosis. So that's very interesting. But there is another interesting factor here, is that normally a yellow ligament, the ligamentum flavum is quite elastic. So there are a lot of elastic fibers in the yellow ligament. But what happens with spinal stenosis? And over time, the amount of elastic fibers is being reduced, and it's rather replaced by more fibrotic fibers. So the yellow ligament is not only getting bigger, but it's also becoming less elastic, and it's actually getting harder, so more compressive. And that's very interesting in this whole pathophysiology of spinal stenosis. So how does this happen? So we assume that there are, over time, micro trauma in the yellow ligament. So this microtrauma, to some extent, will cause some scarring. So first of all, that we're trying to repair this microtrauma. There's a repair mechanism. As a result of this repair mechanism, TGF-beta is released from endothelial cells. This will lead to fibrosis, which makes the yellow ligament harder and also more hypertrophic. And then this is a vicious circle that goes around all the time. And so the yellow ligament is getting thicker and thicker and harder and harder. So why does this cause pain? So first of all, the first theory is that there is mechanical compression. So facet joints are getting bigger, yellow ligament is getting bigger, there's contact to the nerves, and there is this mechanical compression theory. But then again, there's also the ischemia therapy, idea that, first of all, the blood supply to the nerves is reduced, but also there may be some venous pooling. Okay, so some kind of congestion, and that again in a vicious circle leads in the end to pain that the patients are reporting. And we know the typical clinical symptomatology: spinal claudication, pain gets worse, standing and walking, reduced walking distance, discomfort in the legs. We know all that. So different theories. It's the ischemia theory and the direct and also the direct compression of the nerves, of course. So now we have to look at our population, and this is a diagram from the German population. So you can see the population is aging. So this is one thing in Western countries, and it's, I guess, even much more pronounced in some other countries, just like South Korea, for example. So in South Korea, I know they have a real issue that the population is getting too old, and the younger population is not really keen about having babies. So this is a real big issue in many populations around the world. But what does that mean for us as the doctors? So we will see more and more elderly patients, and we will see more and more fragile patients with spinal stenosis. And now we have to think about, how do we deal with these patients? So if you have a 20, 30, 40-year-old patient with a lumbar disc herniation, maybe we have much different strategies as opposed to 70 or 80 or even elderly patients that present to us with spinal stenosis. And so obviously we are trying to stay conservative wherever we can. Okay, we try to avoid surgery. But when can we stay conservative, and when do we have to go for surgery? So what I'm telling my patients is, we always try to stay conservative, but there is a point where I really recommend surgery, and that is when an elderly patient becomes less and less mobile. Because it's vital for elderly patients to remain mobile, to play with the grandchildren, to walk around. And because if you don't do that, then the entire system will start to shut down. And that's actually then at a point a very dangerous situation for elderly patients. So we must make sure that especially elderly patients remain mobile. So with conservative therapy, there is so much. There are massages and injections and pain medication and warmth and fungo and physio and everything. But actually there is very little data how effective all of this is. In an attempt to avoid surgery, we're often trying a lot of these measures, but there is very little evidence how much these things help in spinal canal stenosis. I'll get to that again later. And so there is another issue here. What is the natural cause of spinal stenosis? So let's say a patient comes to you, you can see a spinal stenosis, and now you have the option to do nothing. And the patient says, well, what if we do nothing? Well, there is 70% likelihood that everything will stay as it is, which means you have to tell the patient 70% chances that things will stay as bad as they are now. So telling them it'll stay like this for 70 years is not, for 70%, it'll stay like this is not good news. That's bad news because they come to you in a bad situation. 70%, it'll stay as bad as it is or get worse. Small chance maybe that it'll improve. So that's not a very good, that's very not a very good natural cause. Now, the next thing is, if we make a decision, should we stay conservative or should we recommend surgery? We also have to look at the extent of spinal stenosis. So this classification system, which we all know by Schizas, it's predominantly designed for central spinal stenosis. And if you ask me if we have a clinically relevant symptomatic stenosis, type C or type D, and the patient is really suffering from this, I recommend surgery. Okay, anything before that, we can try conservative therapy, we can try injections, unless we have a wide central spinal canal, but the patient is still suffering because of some recess stenosis. This is not so well reflected here, I think. Okay, but if you have a relevant stenosis, type C or type D, I recommend surgery, because I think we really need to make sure that the patient remains the mobility, and because we know that the natural course is very bad. 85, 90%, it'll stay as bad as it is or even get worse. Okay, and that's why in these cases I recommend surgery. Now, there is all kinds of surgery. What surgery? We can say minimally invasive, we can do microscopic decompression. We can do nowadays endoscopic decompression. I'll talk about that later. We have cases where we can only do an interspinal spacer. I'm not going to talk about this here because this is a different story. Okay, but then there are other cases here with relevant accompanying pathologies. So what if you have patient with spinal stenosis and deformity? What if you have patients with spinal stenosis and instability? And there are a lot of these nuances. So I'm going to give you an example here. You can see this is a patient with a significant instability. And as a result, there's also relevant spinal stenosis. Yeah, very bad clinical symptomatology, back pain and leg pain. So what are we going to do in this patient? You know, we don't have time to make this a big discussion round, but for me, this is a clear indication to do what needs to be done. You know, we need to fix this. We need to correct this instability and then fix it and then decompress the nerves. So you can see here, this is a case with pedicle screw instrumentation. We can pull back the deformity. We can decompress the nerves. And these results in these patients are actually very good. Okay? We just need to bear in mind, if this was a younger patient, then what's happening with these elderly patients, 75, 80, 85 years old? We need to bear in mind that in elderly patients, particularly, if we do these kind of procedures, then the complication rates go up, mortality rates also go up, reoperation rates go up, adjacent segment degeneration, and we maybe have to extend the fusion and so on and so on. So once we start with a single level fusion, maybe this is not necessarily a safe option, you know, because sometimes people say, I don't want to just stay minimally invasive. I want to be on the safe side and I want to put in fusion. But a fusion in an elderly patient is not so much a safe option. So you have over 20% chance that this patient will need to come back to you for whatever reason, for a revision surgery, for implant loosening, for pseudoarthrosis, extending, and so on. Okay, so I'm just saying sometimes we don't have another option, but we need to bear this in mind. And that's the reason why in elderly patients, Whenever we can, we are trying to stay minimally invasive. I'll show you another case here. So this is a part of a little bit of a case discussion. Okay, so you can see there's a little bit of a slipped vertebra, but it seems to be a much more stable situation than what we had before. You can see a patient with spinal claudication, and this is a severe type D Schitzers, according to the Schitzers classification system, type D spinal stenosis. And here, in this case, I opted to do an endoscopic decompression. And this is this picture from that patient that I just showed to you after an endoscopic decompression. So it shows you already with endoscope, if you do it technically in a good way, you can really fully and thoroughly decompress the nerves. So I'll talk a little bit more about this later. From my point of view, I personally believe the microscope is the gold standard. And I think anybody who works with such delicate structures, very delicate dura, delicate nerve fibers, these are very, very delicate structures. I believe anybody today should grow up with a knowledge of microsurgery. I personally was very privileged to grow up with Michael Meyer, and we grow up with this technique. It's just whether we do cervical surgeries, whenever we work around the dura, we work with a microscope. And the microsurgery has many advantages. You have very good visualization. You can zoom in. The microscope helps you to bring in a lot of light. Then you can make smaller skin incisions. And when you can make smaller skin incisions, then patients have less wound pain and they can be mobilized faster after surgery, get back to their activities faster. We have less blood loss because we can see every little bleeding and then stop that bleeding in comparison to open surgeries. When we have smaller wound areas, then we have lower infection rates. That's very important because infections can be catastrophic. We all know that. We've all had these cases and we all know that they can be catastrophic. So if we have anything to reduce the risk of infection, that's really great, especially in elderly patients. And so on. So I believe nowadays, the year 2025, the microscope should be the gold standard for anybody. And then you can see, you get a very good visualization of the nerves, of the dura. This is like a view from a microscopic surgery, okay? You can use diamond burrs, you can use sharp burrs, and then you can decompress in your structures. Like you can see here, the recess is fully decompressed. We control the bleeding, and that's then basically the end of the surgery. So the microscope is very good. But with the same idea, why we nowadays recommend to use the microscope coming from open surgery to microsurgery, I recommend going to endoscopic surgery for exactly the same advantages that we saw from going from open to micro. And we will see the same advantages going from micro to endo. So I will talk a little bit about this later. And I will have a few words on the endoscopic technique. So basically with the endoscope, you can treat any kind of pathology. It's not so much about the endoscope as such, it's more about the surgeon. Do you feel comfortable with the endoscope doing a disc herniation, a cervical pathology, a thoracic disc herniation, a lumbar spinal stenosis, or, generally speaking, you can treat any kind of pathology very nicely with the endoscope. So it's much more of where are you with your learning curve, and you feel comfortable to treat this or that pathology. But at the end of the day, we have all the approaches that we need to address any kind of pathology that we see. We have transforaminal approaches, for example, for foraminal and extraforaminal pathologies. We have the posterolateral approach, and this is my favorite one here, I'll show you why later, is the interlaminar approach. But there is no best approach. So the approach really needs to be modified in accordance with the underlying pathology. And now we are talking about spinal stenosis. So what approach do we need? These are the structures that need to be decompressed, okay? So the hypertrophy of the hilar ligament, hypertrophy of the facet joints. You cannot decompress this with a transforaminal approach. You can maybe reach this area here of the recess, but you cannot decompress the central spinal canal, and obviously you cannot go over the top because you would have to go through the dura, okay? So for a full, thorough, over-the-top decompression, left and right side, you really need the interlaminar approach. Now we also have a wide variety of different tools. We have burrs, we have Kernzons, we have different endoscopes. You can see here, smallest endoscope. This was designed for cervical pathologies. This one was designed for lumbar soft disc herniations. This one is the one that I recommend for over-the-top spinal stenosis decompression because the working channel is a little bit bigger because we have two channels for irrigation, because there's a lot of debris when we work with a burr and we need to get rid of bone debris, for example, or yellow ligament. So this endoscope here will definitely make your life easier. And now I'm going to show you a surgery. So basically, for me, I have a similar strategy doing this endoscopically, the same as when I do this with a microscope. I go to the cranial lamina, I detach the yellow ligament from the cranial lamina, and then start to remove it. And that's what I'm doing here in this short video. I'll show you. I pull down the yellow ligament. So this is cranial, right side is caudal, okay? And now we start to resect the yellow ligament. You can use the scissors for that. You can use Kernzons for that. Now, once I start removing this, you can see the epidural fat tissue slowly coming. And this is a real-time video of how you do the surgery. You know, now you can start to work with a small Kernzon. I'm just going to let you look at this a little bit so that everybody gets the same idea. There are a lot of tools available, but basically I can tell you that I'm doing all of my surgeries with just 3 or 4 tools. Small Kernzon, big Kernzon, scissors, dissector, and the burr, and that's basically it. Okay, now you can see the dura coming. We start decompressing the central spinal canal. Then we continue decompressing the ipsilateral recess until we can see, like we can here, that we have fully decompressed the ipsilateral recess. I must still remove this part here in the caudally exiting area, but now you can see you have a super visualization of the neural structures. You can see the nerve, you can see the shoulder of the nerve, you can see the axilla, and you can see that we have decompressed everything. And then, and that's an easy part of the surgery, you can go over the top all the way to the contralateral side. You must always see with your instruments what you're doing. So look how I'm rotating the camera. And now you can see what I'm doing with the tip of my instrument. That's very important so that you don't work blindly. And then you fully decompress the contralateral recess also. Then we do a final inspection. Is there any bleeding? You know, is there maybe still some bone or yellow ligament that you want to remove? Okay, and otherwise, then this is how you close and finish the surgery with just a single stitch suture. And this has many advantages. I'll talk about this a little bit just now. So patients can be immediately mobilized. They don't need a brace. They can be discharged 2 days after surgery, but that's only because of our reimbursement system. So, you know, with our reimbursement system in Germany, the patients have to stay minimum 48 hours. That's just the way that it is. In many cases, I think that you can actually do this on an outpatient basis. And then after 10, 14 days time, they can resume any kind of activity that they like in the spinal stenosis cases. So where are the advantages of the endoscope over the microscope? I told you my background is I've grown up with a microscope. The microscope is very good. You get a very good visualization of the dura of the neural structures, but the visualization with the endoscope is even better for a number of reasons. It's 4K imaging systems. You don't have a view from 20, 30, 40 centimeters where you simply zoom in, but you are very, very close to the dura, like let's say 2-3 centimeters. And then you have a 25-degree angled optics. So you have a very wide view where you can look cranially underneath the cranial lamina, caudally underneath the caudal lamina. You can follow the nerve root. So the visualization is even much better than with a microscope. I'm showing you a video here. I'm really exaggerating now, okay? So I'm really going in. This is just for demonstration, but you can see you do not get that kind of visualization. You don't need to get that. I did this video for demonstration purposes, but the image quality that you get is unbelievable and really much better even than with a microscope. Other advantages. I'm sure you have this issue in Egypt. We definitely have this here, and in many other places around the world, the number of obese patients is increasing rapidly, and this is a real issue for a number of reasons. For infection, if you have to do fusion, the rate of implant failures and so on and so on. For me, I must say, when I have to decompress the spinal canal, I'm very happy that we have the endoscope, because it doesn't make a difference if the patient is 50 kilos or 150 kilos. You simply put in the endoscope a little bit deeper, but then you're doing the same surgery. So just yesterday, I had the surgery of a 105 kilo lady, 105 kilos, but it doesn't bother me. And then it becomes really elegant when you have a very obese patient and you only do this kind of an incision. And then you finish the surgery in a patient like that with a single stitch suture. Or if you can look at here, this image on the right side, if we do a posterior foraminotomy and you have to make an open incision where there is the skin going like this, there's a very high risk of infection or wound healing problems. So very nice technique, especially for these cases. And then you can finish the surgery like that, small incision, single stitch suture, and then you can do single level cases, or you can do multi-level cases, and not only easy cases, you can also do difficult cases when you, obviously when you have the experience, okay? But then you can see here, this is an advanced stenosis, and that was a 4-level stenosis actually, from L2 to L5, and L5 is 1, we only needed to do the recess. But this is what it looks like immediately after the surgery, and this is what it looks like basically 10 to 14 days after the surgery. The wounds really heal nicely. And we all know when we are trying to make very small skin incisions with a microscope, now the surgeon is very enthusiastic. We try to make this very small skin incisions, but then we put a lot of pressure. We put a lot of pressure on the surrounding skin with the retractors. And this is not so good for the skin. And this is what can happen. So I'm not telling you any romantic stories. You can have all kinds of complications with the endoscope also. You can have dural lesions, you can have epidural hematoma, you can have recurrent disc herniations. So we don't change that. But the risk of infection or wound healing problems is virtually zero. There's never zero, but it's as close to 0% as you can possibly get for a number of reasons. Very small skin incision. There's never any pressure on the skin because the endoscope is inside, okay? So there's no cavity where bacteria can get in. If they would get in, then you have a lot of saline solution, sterile saline solution, where anything is immediately being washed out. Okay, so there are a number of reasons that explain this extremely low, almost 0% of infection or wound healing problems. As said, you can have other complications, but infection or wound healing problems almost 0%. But there is a learning curve that's very important. And I very, very much recommend anybody who's learning this technique to take it very easy. Don't be overly confident and courageous, and because this will backlash. You really need your time to learn this properly. And this is an investment into yourself, into your department, into the treatment of your patients. So it needs time to grow. You really need to take it easy in the beginning, start with easy cases, and then later on, so start with easy discectomies, for example, and then only later on, much later, you start doing over-the-top decompressions for spinal stenosis. So which means that when you have grown up with the microscope, there is a blending phase. So first of all, you start 100% microscope, and now you start to do your first endoscopic cases, but you have to do easy cases. But over time, you will see that you're doing more and more and more cases endoscopically with more experience. Okay, and then you can see, okay, the number of microscopic cases that I'm doing is getting less, and the number of endoscopic cases is getting more. And this is what we could call like a micro endo blending. And it simply depends on your personal learning curve and the surgeon's preference. Now, there is a lot of teaching material out. Maybe have a look on YouTube. We have a lot of YouTube videos, publications. You can come and join some of our endoscopic spine surgery courses. We have one course coming up this week if you are feeling very spontaneous to come to Munich, Thursday, Friday, Saturday, and you get hands-on experience, and we have lectures. So you can come join us anytime. And maybe the latest edition that we have, which was with a professional film team, this is out on the Revo Spine YouTube channel. And there's a lot of effort you can see here with these videos that were made and x-rays flying in and videos flying in. And we're really trying to explain this technique to beginners step by step, how to hold the endoscope, where to make your skin incision. So this is modular. We have now published 6 modules, and I think next week or the week after we will publish module number 7. And then every 2 or 3 weeks, there's a new module coming. So maybe have a look for these videos, because I really think we try to make a lot of effort teaching this to beginners of the endoscopic technique. So thank you very much for inviting me to this fantastic meeting. And yes, I'm sure there are plenty of questions that you might want to ask or discuss. Thank you.
Thank you so much, Christoph, for the presentation. As a first question come to you, what about decompression in spondylolisthesis or in scoliosis?
Mohammed, if you have an additional degenerative scoliosis, so first of all, you have to make a decision. It doesn't depend on microscope or endoscope. You have to make a decision. Is this something that I can still treat minimally invasive, or do you have to correct and add fusion? And now this is really very difficult to answer this question. You really have to see, is it a fixed deformity? Is it a very unstable situation? You saw the instability that we had just now. We need to fix this, I think. Yeah, so sometimes we cannot avoid fusion, but whenever it's a fixed situation, but there are so many parameters that influence this particular decision making. So it's very, very difficult to say this is how I always do it.
Regarding
you have an 87, 90-year-old lady, and you think, well, if this lady was 30 years younger, I would choose something different. But here, I'm only trying to do this. Or there are so many factors that really play a role. Yeah, the properties of the bone and osteopenia and osteoporosis and so on.
Okay, regarding you always go from the complaining side of the patient. I mean, if the complaint from the right side, you go from the right side.
Well, it depends.
You can leave the left side, or you.
This is
to decompress all the stenotic levels and even relatively stenotic levels.
Well, this is a very important question. And this is the very important part of preoperative planning. So if you can see that the level has a rotation, for example, then we come from the convex side, because this will make going over the top to the contralateral side easier. If you have tilting, then we will rather approach also from the convex side, because you can preserve more of the contralateral facet joint. Generally speaking, we come from the side of the patient's predominant complaints. And the preference is, if you have an overall stenosis, that we decompress left and right, unless you have a very good reason that for whatever reason this patient only has really only right-sided symptoms. Then maybe you can come up with a decision for yourself to only stay on the right side. But that also depends on the case. How bad is the left? Do you fear that the left side will come in 6 or 12 months time? Then I would rather decompress it also. But it's a very important part of preoperative planning.
Christoph, do you inject your patients epidural steroids before the surgery, trying to give them a chance by doing lumbar caster or something like this?
You can do this when you have a mild stenosis, and then also the patient feels a little bit, it's also a psychological factor, to be perfectly honest. And the patient feels that we really tried everything to avoid surgery, and if it doesn't get better, then you can still discuss with the patient if it's maybe not better to go for a surgical decompression. If there is a type D stenosis, on the other hand, I think you need to also tell that, the patients come for us and they ask for our advice as an expert, and we need to give it to them. And then I'm telling the patient, listen, you can do injections and probably you will feel better for a short while, because whenever you do put a local anesthetic to the nerve, and you block that nerve, you'll feel better. But only for as long as the medication that we put to the nerve works, and then you'll have the same problem as before. So I think the patients, they really want our advice. And then if you have a Schitzer's type D stenosis, I think we need to tell the patient, listen, of course you can maybe try an injection, but to be perfectly honest, I think what you need is a surgery. And that's what we need to tell the patient, because they want to look for our experience and our advice. And then that's what we need to tell them also.
Do you have experience with the radio frequency, and what about the complications that can be anticipated?
Well, the radio frequency is not so much, Mohammed, it's more like for the facet joint symptomatology. We don't denervate the nerves. So the topic today is that of spinal canal stenosis. And I've seen many patients, they come to us and they say, the doctor's already done facet joint denervation, but it didn't help me. And then we can say, well, I'm not surprised, because, going to the facet joint capsule outside doesn't solve the facet joint hypertrophy inside in the spinal canal. So not for spinal stenosis. You can try it, other cases, but not for spinal canal stenosis treatment.
Totally agree with you, Christophe, that spinal canal stenosis, when it is type C or D, as you presented, and the patient is complaining, it is a surgical indication, quite clear surgical indication.
Yes.
Other methods of treatment may be in relative stenotic levels, and it alleviate for a while. And sure, epidural steroid injection can be type of conservative management, but radiofrequency ablation for the facets is not an ideal. This is all the questions that we had, Christophe, for your presentation. It was amazing as usual, and I hope that you can find time for us to attend one of our courses in person. I know that you have some commitments in Germany, so thank you, Christophe, and happy to have you among us, and see you in
hope to see you soon.
Next events, inshallah.
Mohammed, it was great to see you and everybody else, and thank you for the invitation.
Thank you so much, sir.
Thank you.
Hope to see you soon. Have a great
Inshallah.
conference. Bye-bye.
Thank you, sir.
Bye.
Bye-bye.
So we will continue the program, and I am happy to have Abay Nenni. Abay Nenni, actually one of the famous guitar players, one of the famous athletes in Asia Pacific. He is the AO Spine chairperson of Asia Pacific region. Abhay practicing spine in Mumbai, India, and he is one of the famous scoliosis surgeons and deformity surgeons, but today we will cover thoracolumbar trauma from A to Z. Abhay, happy to have you among us.
Thank you so much, Mohammed. I was looking forward to today, and I loved the lecture before mine, but I'm going to draw your attention now to another scenario, which is again very common in our practice, and that is, simply the thoracolumbar fractures. So this is a lady. I hope you can view my screen, because I'm just going to go ahead.
Yes, we can see it, Abhay. Go ahead.
Thank you, Mohammed. So this is a lady that came to us in the early part of the 21st century. And she, there was surgery written all over her. If you see, it's an unstable fracture, complete neurology, acute traumatic. I mean, on any grounds, this should have been a surgical candidate. But while we waited on her, just see what happens. She, got better the very next day, just by, without anything. And within like 2 or 3 days, she was on her feet. And now we have almost a 20-year follow-up on her. And she's completely healed, much against all the odds. And, that's where this whole contention or a contentious issue of thoracolumbar fracture comes in, that everything is not as easy as it seems. And there's so many twists and tails to this story. Let's start by an office scenario. Once again, you have a young guy and you're the attending in the casualty, and you've been referred this patient with a burst fractured L1. It looks unstable. the immediate questions that strike you. Should I do a CT? Should I do an MRI? Should I do steroids? Let's just take some of these questions one at a time. Methylprednisolone, what do you guys feel about it? Everyone has been through the Bracken trials, and there was NASIS 1, NASIS 2, NASIS 3. And there's a controversy about methylprednisolone, and the data that comes out is that if you can get to your patient with a neurological deficit because of a traumatic injury within 8 hours, there is some role of methylprednisolone to work. Now, this becomes very, very difficult in countries like ours, probably in yours too, because 8 hours is a really short time window from accident to arrival to casualty. So most of our patients technically shouldn't be getting methylprednisolone, but sentimentally we all do feel that we should be giving methylprednisolone. The reason why they say you don't give it when it's not indicated is that it has too many GI complications. But in reality, we all feel that there's nothing else available. We've all had great experiences using methylprednisolone with neurodeficit in tuberculosis, infections, lymphomas, and tumors. And we've really not had too many bad experiences. And I echo this from various studies where they, interviewed spine surgeons like you and me. And most people said that regardless of what the trial says, if I am the person who's had that trauma and I've been wheeled into casualty even 12 hours after the injury, I'm going to ask my surgeon to give me methylprednisolone. So this is a controversial issue, but I'm still sticking my head out and saying that I rather use methylpred than not use for whatever it's worth. And, I rest my case. The next question is, would you do an MRI scan or a CT scan? Once again, this guy, a typical fracture, once again, the thoracolumbar burst fracture, he's come to your casualty. Now, there are pros and cons for both. When you do an MRI scan, you get to see the neural structures very well. But just think about this MRI scan and you'll think it's a partial burst fracture, with neural compression. But the minute you have a CT, the data gets far more detailed, and, the CT gives you information that the MRI did not. So once again, the bottom line to answer the question, CT or MRI scan, ideally both. In fact, always both. Like whenever you're in a tertiary care setting, ask for both. The advantage of a CT is that you normally send then a road traffic accident patient for a brain CT, and you can always do an extended study for the for the spine involved. It's a quick test like an X-ray. It's available everywhere universally. The MRI, of course, tells about soft tissues. It tells you how the nerves look, but more importantly, tells you how the posterior ligamentous complex looks, and you can get a whole spine sequence. The disadvantage being the time taken, and sometimes you don't have it lined up immediately. But before surgery, definitely get both the tests done. Now, the next big question, should you operate or should you conserve? And for this, I think the core is to identify if the fracture is stable or unstable. And this can get very, very tricky. Let's go through, what we know about stability. So we know from all the textbooks that we've read that there are, the column ablation theory, as they say. So if the anterior column is ablated, which means there's injury to the anterior column and it's disconnected, there's a 30% reduction in the strength of load bearing of that part of the spine. If the anterior plus middle column is broken, like in a typical burst fracture, there's a 70% reduction in the load bearing capacity. Now, this is really unstable. If there's a posterior plus middle, it's still a 65%. So the middle column seems to be the game changer when you look at the load bearing statistics of a fractured spine. A posterior column alone, in the absence of middle and anterior column injuries, would only cause a 25% reduction. So I think that, again, the data out here is loud and proud that the middle column is what you really want to be looking at. Because your spine is like you've seen the famous diagram, it's like a crane with the muscles pulling it back, the tension band, and anteriorly the axis of load bearing trying to pull it forward. And what you need to actually identify is what went wrong in this fracture. Was it a break in the fulcrum of your load bearing, which is the middle column, or was it a tension band failure at the back? And if you can discern this, just being smart about seeing the kind of trauma that is presented, of course the history of injury also would help, then you could actually decide whether you want to do a posterior column reconstruction or you want to do a front plus back reconstruction. If you don't get it right, you've seen all these X-rays failing all the time. These are patients who've had it. The surgeon has got it wrong, and he or she is not actually fixed the anterior column thinking it was stable, and it fails on you. So really, to not get into this messy scenario, you want to understand the injury mechanism, which means, unfortunately, you have to classify the fracture. We hate classifications as surgeons, but for sure, classifications help you think through the mechanism of injury, of course, the severity of injury and the degree and the type of instability. Now, we've all grown up on this, this basic fracture pattern in the 80s. Denis had given this fracture pattern where you had the compression fracture, the burst fracture, the flexion distraction injury, which could be a ligamentous or a bony injury, and then the fracture dislocation. Now, this forms a great basis, though it's now a dated classification, it forms a great basis for understanding of the three columns, because the theory of the anterior, middle, and posterior column was actually put forward by Denis. So it's always worthwhile for all of us to still go back and read what Denis said, because everything else falls in line with the Denis classification. So here's the Denis classification simplified. Now, what this does not cover is the comminution. Obviously, it looks like a two-dimensional classification, and all of you surgeons out there would agree with that bottom graphic, where no matter what the spine looks on the sagittal plane, on the axial plane, the comminution would really determine how unstable the spine was. And to cover for this, Gaines and McCormack actually, looked at, again, this was pretty, about 30 years ago. They looked at a number of fractures treated as per the Denis theory. And then they compared to how those fractures looked on the axial CT scan. And they recognized that the more the comminution, the more the implant failure rate, which means that surgeons were getting hoodwinked by comminution. And we didn't look at comminution on the axial image, and hence they formed what is called now the popular load-bearing classification or load-sharing classification, which again goes through a complicated format. Luckily, in today's day and age, you just type load-bearing classification, you have this picture, and you can, in your clinic, actually, decide where this patient lies. So you don't have to study this per se. But what this helps you is to look at the third angle, look at the axial view of any fracture before you actually call this a stable or unstable fracture. Rather, look at the degree of instability based on the degree of comminution. That's all you need to take away from this this classification. Now, as as researchers and surgeons started understanding fracture patterns more, we realized that the tension band at the back, which is actually just the posterior ligamentous complex, the supraspinous, the interspinous ligaments, the facet joint capsules, even partly the yellow ligaments, the posterior muscles, this PLC, or the posterior ligamentous complex, seems to be the decider, because most fractures come with an anterior failure. So if there's an anterior failure along with a PLC injury, things can be different. And hence, and of course, we knew that neurology is a game changer in terms of management. So the next classification, which was from the spine trauma study group, which became very, very popular in the turn of the century, was the TLICS, or the thoracolumbar injury classification with severity scale. Because what they tried to combine was the injury morphology, which the past two classifications did give, compression, distraction, flexion, extension. But they added integrity of the PLC, or the posterior ligamentous complex, and the neurological status of the patient. Once again, we don't have to necessarily go through or learn this chart, which is, but you got to keep in your mind's eye that when you're evaluating an individual with a fracture, a single patient with a fracture, you must look at the fracture morphology, obviously. You must look at the PLC status. And that's not an easy job to look at the PLC status. How do you identify PLC injury? When the PLC injury was talked about, we knew that, it's often missed 3 out of 10 times on the MRI scan. But today, it's getting smarter with the stir images, etc. So today, the radiologists quote a 90% or 95% probability of getting the PLC injury right based on an MRI scan. But there are some other indicators that you can look for when you look for PLC injury. Of course, you want to also look at the neurological status. And the TLICS classification was a bit adventurous. And they tried to say that if you can score on the TLICS classification, you can actually decide if the patient needs surgery or no. This, of course, is a pipe dream, because every patient is different, as you saw from the first case that I presented. That that lady would have scored high on the TLICS, but she still did well without surgery. And a long follow-up, belies the fact that that was the right approach. So this classification gave to us the importance of the PLC injury and neurology. And then a conglomerate got together and gave to us the AO classification. And I'm putting this as the last classification because this is what most of us follow. And if you, if you go through the next few slides, you'll realize this is the most composite classification. It's available freely, online, and you can, it's very easy to actually understand this classification. More importantly, as you go up the grades in this classification, you know that the injury is more and more severe. So it's a classification that actually scales the amount of injury that's, that's caused by the fracture. So you have the type 1 injuries, which are the compression injuries, the type 2 injuries, which are the distraction or the type B, distraction injuries, and then the translation or the separation injuries, type C. So as you go up the ladder from A, B, C, the injury gets more and more severe. Let's slightly delve into this classification because I'd urge all of you to follow this classification as it combines the whole lot of information that we've had so far. And today it's probably the most composite and easy to follow classification. So type A is failure under axial loading, a vertical loading failure of the anterior column. Type B is a failure of the posterior column, which is typically, an opening failure. And type C is a, failure of both columns. So it's as easy as that. Now, type A is divided into 4 big types, and that depends on which end plate is affected and if the anterior cortex and the posterior cortex is affected. So type A1, which is the least harmful or the least unstable fracture, is where a single end plate is affected, and so that's the typical type A1 fracture where you have a single end plate affected and the posterior wall is intact. Now, why is the posterior wall so important? Because the posterior wall spells the middle column. And all the time we've been saying the middle column is really the game changer, followed by the PLC. So this becomes the most benign version of the fracture. And A2, which is the next bad version, is where both end plates are affected, but your posterior wall is still stable. It's the pincer fracture, which is not so commonly seen in practice. A3 is when now the posterior wall is getting into the mix and you have 2-column fracture, which is an anterior and middle column fracture, but a single end plate is affected. This would be the stable burst fracture in colloquial language. And then you have the A4 where the superior end plate and the lower end plate are affected, and the anterior wall and the posterior wall of the vertebral cortex are affected, which means it's the unstable burst fracture. And these are the ones that are notorious because sometimes, in the A3 and the A4, stability would then be determined by the integrity of the PLC. And that's where the whole thing starts getting mixed up. What about the B types? The B type can be either transosseous, which means that there's a flexion, distraction injury with a break at the back, like a chance fracture, or it could be a ligamentous injury with or without bone, and that would be the type, B2 fracture. That's it. So B1 is the osseous disruption of the posterior tension band, like this. So remember that once you have a B type, you always classify, in 2 parts. You say this is B1 for the L12 and A1 for the L2, because you see the L1. This should be the L1. So the L1, which is actually the body is fractured, there's a single end plate injury with just an anterior cortex involved, so that makes it A1. But between L1 and 2, there's a transosseous 3-column injury, which makes it B1. A ligamentous disruption at the back would be B2. So again, here the L1 has undergone an A3 type of injury, which is the anterior cortex and the posterior cortex, but it has only the superior end plate that's fractured. So it falls into A3. But the instability between T12 and L1 is a B2 instability because the instability seems to be through the ligamentous complex rather than the bone. So here the labeling would be T12 L1 B2 and L1 A3. It sounds sometimes complicated, but if you think about it, it's quite simple. Of course, the anterior tension band injuries, which is B3, is very uncommon. You have a anterior extension injury. These are often fatal because you've normally ruptured the big vessels in the front. So these are not commonly seen in surgical practice. And then the C type, which are the translational injuries, are probably the worst in terms of neurology. So if you have translation, you describe that level as C, which means here there's a T12 L1 C type, but the L1 is an A4 because the L1 has both end plates and the anterior and posterior cortex involved. So I hope by reinforcing and showing you cases, this gets easy. It's worthwhile having this, in your, photo album in your phone, the AO type classification. So each time you see a fracture, you can quickly run through this in your head. No one's taking an exam for you, but it's good for you to know because it actually tells you the severity grading of the fracture. Of course, to better describe the injury, there are modifiers, and you would all agree that if the person had Angst-Bonds or osteoporosis, the treatment would be different. So the AO tried to individualize, per patient. So if it's any of these associated diseases, you label it as M2. And if the PLC is indeterminate, which means you're not sure, it's called M1. And then N determines the neurological status. Obviously, as you go higher on the N scale, the neurology is worse. So this is used to then give, again, a little optimistic move that the AO made, where they tried to give an injury score. And what they say is that if the score, that's the sum total, which means that if the patient has, say, for example, an A3 fracture along with a B2 injury, the score goes well above 5 and this person needs a surgery. Below 3, it's non-operative. Number 4 would belong to the surgeon, which means that if your score comes out to be 4, the surgeon can decide on a case basis. So let's take some examples. So just go through your head. What do you think this might be? I'll give you like 10 seconds to think about this. What sort of a fracture might this be? So for those of you who got it right, L2 is an A3 fracture because it's a superior end plate and both the anterior and posterior cortex is involved. As per the history, N0, and of course there's no PLC injury. So this would then have a score of 3, which means that this can be treated non-surgically, right? What about this one? You can clearly see that the bone involved, let's call it L1 for now, has a A3 type of injury, most likely the superior end plate and both anterior and posterior cortex. And there's Cauda-Equina syndrome, so that goes to N3. And when you start scoring it on the AO score, you find that this person should have a surgery. Logical. I think all of you would agree that you would have operated this patient. So in the end, when you think about classifications, all you need to know is think about the mechanism of injury, look at the PLC, look at the comminution of the bone, and look at the patient as a whole, his neurology, his comorbidities, his other skeletal issues like Angst-Bonds, DISH, etc. before you actually make your individual decision. You don't have to follow one classification system. You don't have to toe that line. But as long as you think from all the resources that are available to you, I think you're going to win that game. Okay. Now, the question after this is what surgery would you do? Okay. So now the classification tells you that you want to do an operation. So what surgery would you do here? Again, in your mind's eye, all of you attending, try to think about what would have been your surgery in this case. Would it be a long posterior fixation? Would it be a pure anterior surgery? Would it be a back and front surgery? So for my money, if I was a surgeon here, I would have done this kind of an operation where I would fix from the front, just an interbody cage or a graft, and probably do an anterior reconstruction because the posterior column is fully intact. You could do this back and front also, but for my money, an anterior column, reconstruction here would be worthwhile because it's a young patient who has a partial neurology. So you want to go ahead and, do a better job here. While in this scenario, the surgeon chose to put an index screw rather than reconstruct the anterior column and still got a good result. So, and in this case, which was a type C fracture, I think all of you would agree that a back and front job would be the right thing. So, I mean, the question that resonates here is that when would you need to do an anterior reconstruction and when can you get away by a posterior surgery alone? Of course, when we mean anterior reconstruction, it does not necessarily mean the anterior approach. Anterior reconstruction can be done from the back, but would you want to take that effort or would you get away? As you saw from the last 3 cases, which were similar to each other, 3 surgeons have approached it differently. So, you want to ask yourself which surgery is optimum. And the concern about doing a posterior surgery alone, which is so easy to do, is that if you don't reconstruct the anterior column, it's going to fail on you. And, you would agree that more the comminution, more the requirement of an anterior reconstruction. And these are 2 contrasting cases with again similar injuries, but the one on the right, the bone is fully crushed, the body is fully crushed. So rather than let it reconstitute, you would want to reconstruct it. The problem of an anterior surgery in an acute setting, we all know that if you go in anteriorly, the bone is all soft, too much bone comes out in your hand, there's a lot of bleeding. Your ability to correct the kyphosis, traumatic kyphosis, is very difficult from the front. You need a posterior long lever arm to correct it. Your instrumentation is tacky because you just have cancellous screws, one up, one down. The windshield wiper effect can get into play. So how do you decide? This is a chart that I normally follow, that more the comminution, more likely that you need an anterior reconstruction. Mind you, here anterior does not mean an anterior approach. It means an anterior reconstruction by whichever approach you prefer. More kyphosis correction required. You would want to, so if you've corrected the kyphosis significantly, rather than leave the anterior column open and free, you want to push something into reconstruct and load share. Lower the fracture level, which means that as you go into the lumbar spine, there's a higher chance you want to do an anterior reconstruction to save levels. Less the number of levels that you're fixing. Once again, that if you're doing a short segment fixation, you'd want to reconstruct the anterior column. And younger the patient, you may want to fix the anterior column for a more long-lasting, robust surgery rather than a sham surgery with the anterior column failing on you. And the exact opposite is for pure posterior surgery, which means that if the comminution is low, you can think about a posterior only surgery. If the kyphosis correction during your surgery is not a lot, you can do posterior tension band fixation. The higher the fracture level, the more posterior you can think about, because you get into the more stable zone of the spine and you're not so much concerned about saving levels. Of course, more, higher the fracture level, the more the number of levels fixed, and older the patient, you would err on posterior. So this is common sense, but it's a good slide for you to take a picture of, and then you can think about this in your head. Of course, I'm going to be giving this entire lecture to my friend Mohammad Khattab, so to share with you all. So y'all, because this is not my data, this is data that comes out to the public. And I'd love for you all to go through this lecture again and again, because that will consolidate the knowledge that we had. So what would you do in this patient? This is an A4 type of a complete burst fracture. You can see there's a translational element also involved, and there's a posterior ligamentous complex injury. It's a young farmer. So based on the data, or based on this chart, you would want to do a back and front surgery, and that's what we did. Okay, so I hope this drives that fact home. What about this one? It's a more older person, 64-year-old homemaker, lower demand back. The fracture is more higher into the thoracic spine. And here you can get away, and the kyphosis correction is not a lot. You can get away with a long posterior fixation and help or hope for the anterior column to reconstitute. The trick here is that if you're, if you're putting your money on a posterior fix alone, it's a good idea to correct the biomechanical axis, which means that do a short posterior osteotomy, like a PCO or a posterior column osteotomy, and get your kyphosis corrected, so the load on the anterior column will be pushed back. So try to do that and make a slight correction in the kyphosis to get your center of gravity back. Now, the other questions that as a resident in the casualty that would bother you is, how early should I post this patient? There are contrasting views, early surgery versus late surgery. And ultimately, the evidence says that it doesn't matter. And it's logically, we feel as surgeons. So if, again, I was the guy in the casualty, with an accident and some traumatic paraparesis, I would want my surgeon to go in really, really soon. The counter to going soon or going in the middle of the night is that your resources are not completely at play. You have a staff that's not familiar, and infection rates are higher in middle of the night surgery. So you want to then think about and weigh the options. I think the takeaway is that do surgery as early as you can, because the evidence doesn't support you to do surgery, middle of the night. Of course, if it's neurology deteriorating in front of your eyes, and honestly, I've never seen a case of traumatic paraparesis, which, from the time that I've seen him, he's deteriorating in front of my eyes. That's really a pipe dream. And it's the stuff that you talk about in lectures, but you never really see it. But then you want to go in like super early. But the big question is that sometimes they come in with paraparesis, but they improve, within hours of while, like the lady that I showed you right at the beginning. I think I would want to wait in such a scenario, because it's a cord that's recovering, and any surgical assault would actually likely stop that recovery. So I normally like to wait till the recovery plateaus and then take a decision whether I want to go in or not, because I don't want to be the guy stopping that, natural recovery that's taking place. The next question that the technician will ask you is that, should I do a long fix or a small or a short fix? Once again, here we all should, realize that if you get it wrong. So here there are two contrasting cases. Once again, for the non-discerning person, the 32-year-old female on the left would look similar to the 32-year-old male on the right, except for us by now that we know the classification system. We know that there's a translational injury on the right, and the burst fracture is significantly comminuted, which means that you could get away in this case with a short fixation. But here, if you did a short fixation, it's going to fail on you. And again, this fact comes clearly through the classifications that we went through right now. And the question is then, how do you decide? For that, you need to know the nomenclature, and you must, it must interest you to know that there's something called monosegmental fixation also. When there's only a PLC injury, you just fix that and you don't worry about fixing the fracture. So there's monosegmental, short segment, which is 1 up, 1 down, a short segment with an index screw, which is the current trend, and then a long segment, which is a minimum of 2 up and 2 down. So what are the indications? So long segment should be done in all dislocations, fracture dislocations across the board. Don't think of short segment. No matter what you do, it's going to fail because it's a 3-column injury. And of course, if there's a high comminution and the bones are weak, maybe osteoporotic, you want to go long, you want to use wires, you want to do everything in your hand. On the contrast, a monosegment fixation is good when the bony injury is very little, like just an end plate injury, as you see here. But the posterior, the PLC is injured and you want to reconstruct the PLC. Again, these cases actually become borderline indications for surgery to begin with. Like sometimes you could just conserve this. Once the anterior bone heals, the PLC injury may not really matter. So it's a 50-50 in my book, but this is a good situation to do a percute monosegmental fixation. It works in this scenario, right? The indications given, are all over the press, but generally if you look at the indications for a monosegmental fixation, many of us conserve these candidates. When you do a monosegmental fixation, remember, you've got to be absolutely sure that the PLC injured is in between the 2 spinous processes of where you're fixing, because it's not uncommon, as you can see here, for the PLC injury to actually have extended at the bottom or at the top, means 1 level higher or 1 level lower, and you'll get it horribly wrong if you fix the level of the fracture and leave the level of the PLC behind. So keep your eyes open on this. If you're uncertain, don't go for this. A short segment, which is 1 up, 1 down, is good for the A1, the A2, A3. A1 is non-surgical, but A2, A3 fractures, which is the, stable burst fractures. You could do a short segment. If it's an unstable burst and you want to do a short segment, it's a trend to do that, MIS, then you want to do an anterior along with a posterior fixation. And of course, in the B1, B2, you can do a short segment. So here's a typical case where because this fracture was in the lumbar spine, the surgeon, that is me, chose to, skip or minimize the levels of fixation and then do a back and front with a short posterior fixation. Of course, today I'm not a fan of this expandable cage because it just goes down on you. I'd rather put in a strut graft or a simple Harms cage. To improve the stability of a short segment fixation, an index screw is now, or a screw into the fractured vertebra, has shown to significantly improve the biomechanical strength of your fixation. And there are enough studies to suggest that a short screw in the pedicle would help. Remember that if you're planning a late anterior reconstruction, keep that screw short, because if it's long, it's going to come in the way of your anterior reconstruction. So that's just a tip that you want to remember if it's playing up in the back of your head. So when you choose short versus long, look for the PLC injury, look for comminution, look for neurological insult, look for the surgeon's experience in, doing a short fixation or an anterior reconstruction. Of course, look at the comorbidities of the patient. I hope this kind of answers the question as to how many levels of fixation you take. Now let's go back to our case, and because now I'm going to throw a little twist in the discussion so far and talk to you about some what we call Desi Gyan or Indian Gyan, because we are fairly conservative surgeons, unlike our German counterparts, and we conserved even this lady with this terrible fracture. So I'm going to raise a slightly, the next 5 or 10 slides are going to talk about a slightly different, contention, that very often we tend to operate because there's a fracture and you think it's unstable. But I'm going to take you through a few, data points that may want you to think otherwise in your practice. I'm going to say that neurology and instability are not absolute indications for surgery in TL fractures. And the commonly indicated reasons to operate a thoracolumbar fracture, let's try to go through them and see what actually literature has to say. And there's enough literature that says that there is no validation to operate a thoracolumbar fracture on the basis of neurology or on the basis of instability, okay? Now, instability in a fracture, as you can imagine, is a time-bound concept, which means that on day 1, of course, when there's a fracture, the bone is unstable, but this is biology and it is destined to heal. So depending on how soon the bone is going to heal, you could wait, and what was unstable today can become stable tomorrow. And there is a level 2 evidence study out there, if you go looking for it, that suggests that unstable burst fractures without neurology do not fare any better with surgery as they would without surgery. And that's a very, very bold statement. And in orthopedic or spine literature, to get a level 2 meta-analysis is not easy. So this is very strong data, my friends. Also, is complete disruption of the PLC an indication to intervene? And once again, the meta-analysis, again, by the guys who actually, formed the TLIX classification, is that there is very low evidence on, operating just because the PLC is injured. So that's again, one important data point. As surgeons, we know that if there's a need to mobilize early, you would want to operate early, but that's a relative indication. Now, is neurological deficit due to cord compression on the MRI or the CT scan? Is it a good enough reason to go in? Once again, the key question that you ask yourself, that is that fragment that's pressing on the nerve the cause of the neurology, or is the trauma that happened at the time of the accident the cause of the neurology? And very often you see these cases like case 1 and case 2 on the left, you see that there's a significant impingement on the cord, but both these had no neurology, while the person on the right with, of course, an impingement of the cord was total paraplegic. So there is really very little evidence to suggest that surgery to decompress the cord or decompress the conus or decompress the canal can actually help in improving neurology. And that again, there is very high level evidence to suggest that, you're not going to really contribute to neurological recovery by doing a decompression. And then they say that if you don't decompress, it'll lead to neurological deterioration. Like I told you in the beginning, normally what you have is what you get, and you'll almost never see a patient getting worse in neurology while he's under your treatment. And the data available also seems to suggest that. So, after studying long follow-ups, you still don't find cases that have deteriorated late because the fragment in the canal was left as it is. Again, this is very, very telling. It's counterintuitive. I agree that it's counterintuitive, but you have now, systematic reviews that have been published all across that suggest that, there is a high level of evidence to suggest that neurologically intact patients have similar functional outcomes, lower complication rates, of course, lower costs with conservative management than when you compare it to surgical management. So I'm just bringing these points out because this is out there in literature. And as young spine surgeons, we don't get exposed to this. And I considered my duty to share with you what, what sometimes gets hidden under the garb of aggressive orthopedics. So I'm going to summarize by saying that steroids, I'd rather give than not give. X-ray, CT, MRI for all. Follow the AO spine classification, but more than that, look at the PLC, ligamental PLC integrity in every patient. Look at the comminution of the fracture fragments, and of course, look at the patient profile and the patient demands. The indication for surgery in neurology is if there is progressive neurology after an injury, or if there's a partial neurological deficit with a significant canal compromise. That those would be my indications to go in if for neurology. And for instability, my indications would be fracture dislocations, of course, flexion distraction injuries, not so commonly seen, and polytrauma. And when I have to operate, I'd like to go in as early as my system permits. And then finally, A plus P, the standard chart, A or P, and then long or short, again, the standard chart. But in the end, try to make your treatment plan patient-specific and individualized, and don't make it institution specific or training specific. I'm an MIS surgeon, so I'll do MIS. I'm an anterior surgeon, so I'll do anterior. Don't go by that. Go by what the situation demands. I'll end here, and I'm happy to take any questions that are pending. Thank you, Mohammed, and thank you everybody for listening to me.
Thank you, Abhay, for the excellent presentation. And of course, you have many questions. The first question, you decided that some patients can be managed conservatively, especially if they are neurologically free. And even in the literature, they are supporting that the outcome equal to the surgically indicated patients. What kind of conservative management do you recommend for patients like A3 or A4 fractures? And also, what about the anticipated kyphosis, which can cause significant back pain afterward, or even some neurological deterioration on the long term?
So thank you for bringing this up. This is a very logical question. I'm going to answer the second question first. That there's again enough data and literature to show that there's a very, very low incidence of late onset kyphosis affecting your function. So, the angle could go, 10 or 20 degrees higher, but functionality or neurology does not get affected late if you've gotten away in the first few weeks. As far as what is the exact management, for me, I go by the pain for the patient because back in the day when I had a short stint in Nottingham, they would actually make patients sit up on the day of the injury if you're neurologically intact, because they believe that dynamic stability, which is from your muscles, is far more important. I normally like to keep them in bed for 2 or 3 weeks, actually, if it's an unstable burst fracture, and put them on in-bed exercises. Each patient is different. A young athletic guy, we sometimes start verticalizing him much sooner. But I can tell you that I would not wait for 2 and 3 months to verticalize this person. I don't heavily depend on braces. I use braces more for for a proprioceptive feedback. And I teach the patients how to hold their musculature, put them on extensor strengthening exercises very fast, and normally mobilize them in the first 3 weeks.
Okay, great. Abhay, what about fixation without fusion? We saw in some cases that you presented, you have long construct, 3 levels up, 3 levels down. So you extend your fixation anchorage points. Do you do short segment fusion and fixation longer, and then you remove the implant later? What is your strategy in managing such a
So
fracture?
again, Mama, thank you. That's a very logical, plan that you fuse short and fix long, and hope that you can take away the implants later on to get back mobility. But again, in a real life scenario in a country like ours, fracture spine patients don't come back for a second surgery, number one. So there's a low chance that this guy is going to come back asking for in fact, in my career so far, I've just had 2 times when the patient came back asking that, you told me that you will take the implant off. Can you take it off? Just 2 times so far, because they can't afford a resurgery and they're happy with their result. The second is that mostly these are thoracolumbar fractures. So if you have fixed 2 or 3 levels into the L1 or L2 or even L3, it does not compromise on the patient's mobility. So it's only when you start going to L4 and L5 when the mobility in a real life scenario gets affected. So I think far too much is made out of going long in a thoracolumbar fracture. And my advice to everyone would be that you'd rather go long than short, unless you're flirting with the lumbar spine, which means that if you're going to end into L4, L5, or S1, you want to really struggle and do an anterior job and do a short fixation.
Abhay, is the type of screw affect your fixation anchorage points? There is a question asking about the polyaxiality or the monoaxial screws.
Actually, polyaxial screws are better. Again, it's a counterintuitive statement because you would imagine that a polyaxial screw has a free head, so it can fail, but the polyaxial screw matches with the rod much better. So the failure at the rod screw junction is the least in a polyaxial screw. So for me, a polyaxial screw would be the one of choice. At this point, I must tell you that all of you guys who work in situations like mine, I think both countries are at par in terms of I'm not going to say poverty, but at least the lack of resources. We all must know the art of putting sublaminar wires and hooks, because these are great bailout options when screws are either you can't negotiate a screw through a fracture, or there's a lot of osteoporosis. Remember, the sublaminar wire can hold the fracture extracortically, and in osteoporosis, it's got much better pull-out strength than the screw, and it costs about 1/100th of a screw. So just learn the art from the seniors who teach you, and keep that in the armamentarium when you take up a fracture.
Abhay, is there any tips and tricks for reducing fracture dislocation in the spine from posterior?
So for me, I would because I do a lot of osteotomies in deformed spine, it's not a huge challenge. You like to go 360 degrees and do an osteotomy to release and get a very easy reduction. When you get the reduction, you want to close so in short, you want to drill down the posterior elements, go ahead in the front and see what's blocking. Sagittal CT scan can tell you what's causing it, and you can actually get a physical reduction. This can get very edgy if the patient is nil neurological. So in the rare scenario where you have a fracture dislocation with no neurology, this can really bite you. And once again, here, I like to use sublaminar wires because they give you a very controlled reduction.
Excellent. So, Abhay, we finished the questions. Thank you so much for your efforts. And I hope that we can meet again in the near future, inshallah.
Thank you, sir. I love the time here. And maybe I'm going to see you again at the EOS session. I just got the call and I'm enthusiastic to interact with everyone. Thank you again,
Yes.
Mohammed. And I'll share this lecture with you on WeTransfer so you can, hand it out to whoever is interested. It'll be a good revision for everyone.
Thank you, Abhay. That's really great from you. Thank you so much.
Thank you so much, sir.
Bye-bye.
Bye-bye. So we will continue with our program, and the next speaker will be Dr. Hamdan Abdulrahman. Dr. Hamdan Abdulrahman is a spine consultant working in Germany in Erfurt Helios Clinic Hospital. Hamdan originally from Egypt, working in Asyut University, but he is one of the traveling spine surgeons overseas, and he will give us nice talk. It will cover spine infection. I know it is very long topic, so we'll see how he will manage in his short time lecture. Hamdan.
Good evening, everyone. Thank you for the invitation. I will cover the diagnosis. The therapy will cover the operative and antibiotic therapy. It will be very, very long. I will prepare it for the next session.
Okay.
Are you seeing my monitor?
Yes, put it in presentation mode so we can see it much bigger. Hamdan.
Yes.
Thank you.
Okay, thank you very much. I will cover these objects, historical review and definition and basics, anatomical and biomechanical consideration in the spinal infection in general, and I will talk about the pathophysiology and the classification of the infection according to the etiology, and we will talk about the diagnostic possibility, start from the clinical presentation to the radiological investigations. As we see here, the spinal infection, it is very ancient and old history, start before century, and it is the first picture in the literature of Egyptian mummies. The Hippocrates was the first one who described the tuberculosis of the spine and differentiated between the capacity above the diaphragm and below the diaphragm. And Bott was the first one described the tuberculous nature of the disease in 1779. We will continue with Laennec, who described the tubercle as the primary lesion in the spinal tuberculosis, and identification of the microbacterium tuberculosis was described by Robert Koch, the German bacteriologist, in 1982. And we will use all over the world, also in Egypt, the BCG in vaccination since 1945. The first description of biogenic infection was described in 1879, and the osteomyelitis described in 1992. Kowalski in 1936 described the large series in the literature, more than 100 above the biogenic spinal infection, and the X-ray examination and X-ray changes in the spinal infection described by Compere and Garrison in 1936. Sorry. Definition and and basics of the spinal infection. We have to identify the epidural space infection known as epidural abscess. It may be primary, this means solitary epidural abscess, or secondary to the spinal infection, secondary to affection of the disc and the bone, secondary to spondylodiscitis. The discitis is a very rare entity in the spinal infection, mainly affect children because of the vascularity of the disc. Spondylitis is also rare. This can be early in the infection of the conservative treatly fractures, such in this case, treatly infection, conservative treated and got infected due to bacteremia and got infected. It's a very rare entity in the spine. And in the literature till 2020, there are 17 publications with 20 cases. Or affection of the disc and adjacent end plates, and it will known in the majority of cases as vertebral osteomyelitis or spondylodiscitis. We have to consider the effect of the infection disease on the anatomical structure and the biomechanics of the spine. The anterior column could be affected in more than 90% of the spinal tuberculosis and also in biogenic infection. In adult, the disc is avascular and the organism will preserve or save the disc because lack of the proteolytic enzymes and avascularity of the disc. In the biogenic infection, the disc can be destructed due to the bacterial enzymes. In contrast to the tuberculous spondylitis, it will be saved when we find the destruction of the disc. This means could be associated with superimposed infections, bacterial infection. Spinal infection present to 7% of all musculoskeletal infection. Described also bimodal description with peak below 20 years and between 50 to 70 years. This description has been changes in the recent years, increase the incidence observed due to increase the susceptible publication and population elderly patient, and due to improve the accuracy of the diagnosis and the diagnostic methods. According to the route of infection, the hematogenous infection, it is the main route of infection, mainly arterial, but could be also venous. Direct or the iatrogenic involvement of the disc and the epidural space could be also post-operatively, which nowadays up to 30% of the spinal infection spread directly could also occur. We have to differentiate between two forms of infection: contagious infection and continuous infection, with affected more adjacent segment. It is a known form in the tuberculous and fungal infection, but nowadays it is also known for low-grade infection and biogenic infection also, maybe due to the depressed immunity and mutation of the organisms. It is very important to differentiate between the systemic factors, predisposing factor, and the local factors. Every factor can decrease the immunity, generally chemotherapy, metabolic diseases such as diabetes mellitus, alcohol abuse, obesity, malnourishment, advanced ages, atherosclerosis, lung diseases, kidney diseases, liver diseases can jeopardize the general condition and cause bacteremia. But the local factors, this means the disruption of the integrity of bone and soft tissue through trauma, spinal fracture is very rare described in the literature. Also, post-operative procedure can cause jeopardize the local immunity. And vascularity in elderly patients with osteoporosis can also decrease local immunity. Foreign body implants, our implants, instrumentation of the spine, and instability such as lytic lysis or degenerative lysis could predispose to a spinal infection. A known theory in the medicine known as locus minoris resistenti. It is depressed localized immunity shown. We can see in these pictures also depressed fracture here, depression fracture of the spine got infected in without any surgery. Also in this case, a case of double level lysis and planned surgery, we have bone destruction after 3 months between the X-rays, destruction of the endoplates, and epidural collection, also destruction of the endoplates. For the diagnosis, we need history of the patient, clinical examination, laboratory investigation, and also radiological investigation start from the X-ray, MRI, and CT. The clinical presentation may start with chronic back pain, non-specific symptom. It may be lead to the delay of the diagnosis and therapy of such cases. May be acutely presented with sepsis, multi-organ failure, and neurological deficit. The neurological deficit mostly due to the spinal abscess formation or instability in late presentation. The typical biogenic and spinal infection mainly present with pain in 90%, mostly subacute during the onset, febrile illness up to 50%, radicular symptoms up to 90%, and mild deficit also detected till 35%. Complete and incomplete paraplegia, it is rare in the spinal infection. Neurological deficit, in particular paralysis associated with epidural abscess mostly. The laboratory investigation, mainly CRP, and up to 80% may be a normal value. Leukocyte count is mostly related to the increased CRP level. Organism isolation could be through blood cultures, recommended 3 blood cultures, and can be positive between 25% to 70%. Abscess function when found, CT guided is also to identify the causative organism. Intraoperative swab recommendation now to avoid negative or to minimize negative culture. We have to take 3 to 5 swabs. Mixed infections, polymicrobial infection isolated from the same infected site, up to 6.5%. Histological examination of the of the tissues is mandatory to exclude associated specific infection like tuberculosis, or to exclude also tumors. The conventional X-rays may appear normal in the first 2 to 8 weeks after the start of the symptoms. Erosion of the end plates above and below can be diagnosed in the X-rays. Segmental kyphosis, that spontaneous fusion, can be later noticed. MRI with contrast middle of the whole spine, inclusive the iliosacral joints and the coronal formation of the spine. It is the gold standard diagnostic method in such cases, with sensitivity more than 90% and specificity more than 90%. Psoas and epidural abscess can easily detected in the MRI. Why MRI of whole spine? To exclude multifocal spinal infection or metastatic spinal infection. It is up to 10%. CT is for the diagnosis important when MRI is contraindicated in patient with pacemakers, to evaluate also the bone destruction, and we can preoperative plan for the reconstruction of the bone defects anteriorly. We can use also the CT postoperative to exclude pseudoarthrosis. In nuclear medicine, also we can search for other foci of infection in the lung, in the shoulder, using PET CT. A treatment option, we will talk about it in another session. The goal of treatment in general to establish definitive microbiological and histopathological diagnosis, to eradicate the infection, to relieve the pain, and to prevent and reverse the neurological deficit if present, to establish the stability of the spine and prevent recurrence of the infection. Thank you very much.
Thank you so much, Dr. Hamdan, for the presentation, and waiting for the treatment in the next time. Although we have some questions, and one of them will asking about the treatment as well. Dr. Hamdan, regarding the differential diagnosis, modic changes radiologically can be one of the differential diagnosis. How you differentiate between infection and the erosive spondyloarthrosis?
It is very difficult to differentiate between them. There are some sequences in the MRI, and both the modic type 1 and spinal infection both are painful, and we can take biopsy from the disc percutaneously under CT to differentiate between them.
Okay. Dr. Hamdan, which is more prognostically bad, TB in children or adults?
In children.
Bad prognosis in children?
In children, because of the growth tendency and deformity later.
Okay. What about the viral infection in the spine?
What about?
Viral infection.
Viral infection, it is very rare. I never seen it.
Okay. Regarding the epidural abscess, Dr.
Are you
Hamdan, you highlighted
fungal or viral infection?
He wrote viral infection. But
No.
I believe fungal infection is
Fungal.
fungal infection used to be very vascular lesions in the spine.
Yes.
Okay. What about the epidural abscess?
Sir, I think Professor Khattab has a problem with connection.
It was the question about epidural abscess. Epidural abscess,
Yeah, yeah,
not mostly, mostly symptomatic and causing neurological deficit. It may be primary. There are some publication about the conservative treatment in primary spinal infection without drainage. I will drain to gain organism, causative organism.
yeah,
We have the era of minimal invasive surgery. We can do it transtubular drain, and we will eradicate the infection through and we will can do irrigation of the epidural abscess. It
yes,
is very important to gain it. The secondary epidural abscess could be treated directly through the treatment of the spondyloschisis. When you have this spondyloschisis, mostly anteriorly. The primary epidural abscess mostly posteriorly.
yes, sir. Thank you so much, Professor Hamdan. I think Professor Khattab is with us now. Professor Muhammad. Okay, he's trying to join. Thank you so much, sir. I
Thank
think
you.
we have no more questions. And thank you so much for being with us, sir.
Thank you very much. Thank you.
Thank you so much. Would you please stop your screen sharing? Thank you so much. Now we will move to the next speaker. Next speaker will be Professor Ali Madawi from Suez Canal University. Dr. Ali, how are you, sir?
I'm fine. Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum assalam wa barakatuh. Thank you so much for joining us, sir, in this very fruitful night.
دكتور خطاب بس بيرن عليا اشوفه عايز ايه بعد اذنك. الو يا محمد، انت اوت دلوقتي ديسكونكتد تقريبا. انت مش معانا، والدكتور محمد بيشير السيشن.
لحد ما هو يدخل معانا
طب
تاني.
خش تاني بقى، حاول تخش تاني. احنا من نفس اللينك اللي انت دخلت منه اول مره.
يس.
من للايميل اللي جالك تخش منه فولو لحد ما تخش تاني. ماشي. لا خير ماشي. سوري دكتور محمد.
Thank you so much, sir.
اهلا بيك.
اهلا بيك يا فندم.
الله يكرمك.
ممكن شير سكرين يا فندم بعد اذن حضرتك؟
حاول ان شاء الله.
Yes, sir.
We need just to
Full screen, sir, please.
Yes. Is that okay?
Yes, sir. Yes, sir. Thank you so much.
السلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله
أهلا بكم
وبركاته.
جميعا. أنا عارف طبعا إن أنتوا دلوقتي بقالكم فترة معانا، فالناس ممكن تكون يعني إيه تعبت شوية، فنتعشى إن شاء الله إن
لا يا
هم
فندم، سعادتك احنا في السبيشاليتي داي بتاع الهيب قعدنا 14 ساعة متواصل يا فندم.
لا يعني عظمة.
حضرتك ما تقلقش، ما فيش مشكلة عندنا.
احنا عموما our talk would be a light talk because we are tackling a very wide area of pathology, the atlantoaxial instability. This, I have no disclosure. This joint actually is one of the most complex joint in the body, because it has a wide range of motion and very characteristic for the bone morphology of the atlas and the axis vertebra, as we've seen here in the images. This joint is responsible for 50% of the total neck rotation. The rotation for yes, for no or yes. Also, it is responsible for 10 degrees of flexion and extension and 5 degrees of side flexion of the neck. So it's very, very important in terms of function and of range of motion itself. These 2 points, the axis and the atlas vertebra, are joined together by a very complex ligamentous and muscular structures. There is a very range of ligaments connecting these 2 points from front and from the back. As we've seen here, the cruciate ligament is the most important ligaments joining these two bones together, especially the transverse band, or we call it the alar ligament. This ligament is moving from the alar tubercle from the right side of the atlas to the left side, to the alar tubercle on the left side of the atlas, and running just behind the dents of the axis vertebra. This slide summarizing the anterior ligaments, and the most important one is the cruciate ligament and the posterior ligament, and the most important band of the posterior component are the muscle, not the ligament. So we have two major components here for the stability of the atlantoaxial segment. Anteriorly the cruciate ligament, and posteriorly the paravertebral or paracervical muscles. That's why as this muscle is not well developed in children, so pathology in the children with this area is very common. Also, the musculatures of this joint is very complex. In these images, we can see a multi-layer extending from the superficial long muscles down to the deep short muscles. Is very, very complex muscular connecting these two bones together. And we have to know this very well, because any approach to the atlantoaxial segment is violating a lot of muscles, especially the short muscles, which are very important. That's why usually your technique should end with a very stable fixation technique, because you're violating important muscles in your way to do your techniques. And finally, it ends with the vascular structures around these joints. The vertebral artery, which is a very, very important part of the circulation of the brain. This artery moving from C2 vertebra to the C1 vertebra. And as you've seen here above the arch of C1, you can see the vertebral artery here above the arch of C1, where it passes the dura to join its fellow, forming the vertebral artery, the basilar artery in front of the brainstem. So very near to the atlas and the axis, the vertebral artery, which is very important structures, and also the epidural venous plexus is very rich in this area. Looking closely to the blood supply of this joint, we can see that the blood supply of these joints is coming from an apical arcade and from below through the anterior ascending artery from the vertebral artery. So having circulations that coming from above and below, so we have a watershed zone. This is typically at the base of the dens of the axis vertebra. That's why fracture at this area is very crucial regarding the healing power. So we have to know also this peculiar blood supply of this joint. And another important issue, which is the vertebral artery here, also from 20 to 35%, you have an anomalous vertebral artery, one small and one very large artery. This large artery can be extending through the lateral mass of C2, eroding the lateral mass of C2 and the pars and the pedicle. This is where we're using the screwing system. So if you have this anomalous vertebral artery, you can see it either from the bone on the left side here. The bone is very eroded. That can be clearly evident on the CT scan. We'll see examples of this, or through the CT angiogram, where you can see the abnormal large vertebral artery. If you have this abnormal large vertebral artery, so you know that the bars and the lateral mass and the pedicle of C2 are very critical to put a screw in this type of the vertebra. Again, this is a normal vertebra, axis vertebra. If you look from below, you can see the vertebral artery groove on both sides of the vertebral body, just below the lateral mass. This vertebral artery groove, you can see it on the CT scan, as we'll be showing soon. And through our publication, which is about the variation in the vertebral artery groove in the axis vertebra, you can see in the middle the normal vertebral artery groove here. And on the right side, you can see the high riding vertebral artery. On the right side, you cannot do screwing for this vertebra on that side, and this is very, very important. You can see this cadaver images on the sagittal CT scan, and you know that the vertebral artery is high riding, and that's why you have to avoid screwing as this system. Again, through our publication about the transarticular screw, you can see that the normal vertebral artery groove on one side and the huge vertebral artery groove on the other side, that's quite clear on the coronal CT scan. there is a riding vertebral artery here. This is where a screwing, any screw, whatever Goyle technique or Goyle-Harf technique or transarticular screw technique will be contraindicated. Now, how about the atlantoaxial instability? As we've seen, the atlas and axis is stable through the bone morphology, through the ligaments, through the muscles. So if anything that disrupt any of this, the bone or the ligament or the muscles, you will have ending with a atlantoaxial instability. How atlantoaxial stability present? Because usually the atlantoaxial, if there is instability or subluxation, there is a spinal cord compression, and this ends with a various grades of myelopathy. Usually the patient presented with neck pain and with or without neurology. Many of these patients are coming intact. Sometimes they come with either Brown-Séquard syndrome or paraparesis and quadriparesis from the spinal cord compression with a varying degree, either with, sometimes we see the complete cord pathology. So the causes for atlantoaxial instability could be traumatic, and this might be misleading with some cases of osteodontadium. We'll have a lot of examples on these categories. Also infection, either Grissel syndrome, which is upper respiratory infection that's associated with soft or ligamentous instability of C12. However, if you have a spondylodiscitis of C12 or a bone infection of C12, you can have different categories rather from the upper respiratory infections that end with atlantoaxial subluxation. Also, Down syndrome, because of laxity, present with atlantoaxial instability. Inflammatory conditions like rheumatoid, we can see a lot of cases of this with Bannas formation and ends with atlantoaxial instability. Some cases of errors of metabolism like Morquio syndrome, very rarely in our country. We can see tumors like aneurysmal bone cyst or neurofibromatosis, syringomyelia, and some miscellaneous causes like fetal warfarin or Conardi syndromes. The most important of this is trauma. How will we have speak a bit about trauma later on? So we have a lot of diagnostic problem here with these joints. That's also we have a lot of surgical techniques, starting from the posterior surgical techniques, like in 1993, the first wiring technique, the Gallet fusions. Then they broke in 1978 and modified in 1991 by Sontag. Then came in 1975 the clamps technique or the Halifax, which is all this is not today is not a primary way of treating atlantoaxial instability. In 1987, Magrel introduced the transarticular technique, and it was famous at that day. But when the Goyle introduced his technique in 1994, and this was upgraded from a normal screw to a polyaxial screw in 2001 by Harmes, it became the most important and most famous and most widely used atlantoaxial technique fixation. Also, we need anterior fixation in some cases like transodontoid screw, which is the famous anterior managing policy. You might have an anterior transarticular or anterior oral plates, which is very rarely used. Occipitocervical fixation is used when the segment is destroyed and we can do only single anterior atlantoaxial fixation. You resort to fix the occiput to overcome the bony distractions. But we try to avoid occipitocervical fixation because it ends with disappearance or complete loss of neck motions. This is some examples for the Gallet or Broke and the Sontag fusions, and also the Halifax clamp. All this is either condemned, or sometimes we use the wiring as a conjunction with other stabilizing technique. This is how we use the Gallet fusion or how we use the Brock. This is just to know, sometimes you might end with unilateral fixation, and in these cases you need to do something supporting the unilateral fixations. That's why you have to be familiar with this wiring technique. It's an important technique that you might need and you have to know. Then after the wiring technique came the transarticular screw fixations, and the problem with this is that these transarticular fixation, you need to have two important conditions. Number one, you have complete reduction of the atlantoaxial instability. Otherwise, it will be contraindicated because, as you see, the screw is trajectorying to the anterior tubercle of C1. But if there is the persistent subluxation, the screw will be low enough to hit the vertebral artery. The other problem is that you should have a normal vertebral artery on both sides, because also, again, high riding vertebral artery is a contraindication of the transarticular screw. And in most of the cases, we use the Gallet fusions in conjunction with the transarticular screw to convert a 2-point fixation into a 3-point fixation. The problem with C1 or C1-2 transarticular screw is that we do the normal approach, but the screw trajectory is coming from percutaneous at the level of C6. So the incision is different from the entry of the screw. And you have to see the atlantoaxial passage joint, and you can see the, in order to be sure that your screw is going through from C1 lateral mass to, from C2 lateral mass to C1 lateral mass. That's why you have to expose the facet joint to see the screw going through. This is number one. And number two, to do fusion of the facet joints.
I think we lost the connection with Dr. Ali, or what?
Yes, I think so. He's to connect again. Dr. Ali?
اتصل عليه. He is signing in. Sorry, Dr. Muhammad, it occurs sometimes, you know, you lose,
Yeah, of course,
lose
sir,
the
of course.
connection.
Of course, it's not a problem. ممكن يجوين تاني يا فندم، مفيش مشكلة
هو
خالص.
هيجوين حالا، انا كلمته.
مفيش أي مشكلة يا فندم خالص.
كلمته. I can answer the question which is delivered by Dr. Gamal Qasim.
Yes, please, sir.
But just I will answer Dr. Ali. Dr. Regarding the atlantoaxial instability, the patient will lose something like 50% of the rotation, because atlantoaxial motion is mainly rotatory motion. So the patient can lose 50% of this motion, which is actually tolerated. So once the patient is candidate for atlantoaxial fusion and fixation, go ahead and don't be worried, it is tolerated by the patient. Dr. Ali is signing in because he has some problem with the computer. Also, I'd like to highlight something because in the last 2 weeks, I managed some cases. It belongs to the previous presentation, the infection, and it was related to post-operative wound infection, actually. These were not my patients, but these are patients underwent surgeries for a long time, and they came lately by pseudoarthrosis, and I opened them to manage and treat the pseudoarthrosis, and I found infection. One of them was evident clear infection inside, and the other one, I used to have a culture from any previous surgeries, and with cultivation and doing culture and sensitivity for the harvested specimen, we found also infection, which was MRSA. And this highlighted the importance in any revision surgery. You need to take some tissues for sampling and culture and sensitivity, and even you can do something like long time culture for low virulent organism like Acinetobacter, which can be grow within 15 days. So you need to do some extended cultures as well.
Yes.
And these are common causes for pseudoarthrosis, and the patients can come complaining from back pain after fusion surgeries due to the pseudoarthrosis, but actually it is an infection, low grade or either really virulent organism. And you can anticipate such scenario even after 2 years from the index surgery. Also, one of the complications that we can see is the development of the epidural abscess. Development of epidural abscess, once the patient develop it, that means it is really one of the procedures that you need to drain this abscess before causing neurological symptoms. And to do so, you need to introduce epidural catheter. Epidural catheter, it may be something like the smallest Nelaton catheter, or even the epidural catheter used for epidural anesthesia. We introduce it and try to suck the epidural abscess and take culture and sensitivity and give the patients the proper antibiotic accordingly. And they used to show improvement afterwards.
But for the catheter, sir, do you guarantee that complete removal of the caseous material in case of TB, or the pus in case of epidural abscess, or you have to train it?
I cannot guarantee, but sometimes if it is limited to certain area, I can do something like laminectomy and guarantee the removal. But
Yes.
In the couple of cases that I met, it was abscess extending from the lumbar spine up to the cervical spine. So the whole spine is exposed. I cannot open the whole spine, and I cannot do laminectomy for this long distance. And especially the patient was neurologically free. So I decided to do this in a minimally invasive option, only to decrease the contamination and take a biopsy for culture and sensitivity.
Yes.
But for limited cases, we can do laminectomy, of course, and the proper debridement.
Yes, sir. Yes.
I can encourage our colleagues to ask questions in the Q&A dialog box till Professor Ali appear again.
I think we have a question from Dr.
Yes.
Abdulrahman Sayed.
Dr. Abdulrahman, for C12 fixation in pediatric age group, if you will do it, for example, for fracture, and you are waiting for healing of the fracture, so you will remove the implants after fusion, after healing of the fracture. So it is okay for this. But if you are fixing for certain kind of instability or ligamentous injury or infection or tumor, it is fixation with fusion. So you don't need to remove the implants after the index surgery. And it is okay. We have some cases with C1, C2 rotatory instability after infection or after some tumors, and we fixed and diffused C1, C2 with favorable outcome for the patients after the surgery. I will call Dr. Ali and see if he is available or not. He faced a problem with the network, and then when he opened the computer, he asked to restart and install some new softwares. So it takes time, but he will log in through the
mobile.
the link now. Yes.
Okay. I have a problem with the Wi-Fi in the hotel, so I logged in through the mobile data.
Yes. Dr. Abdurrahman Said is asking about the rigid collar and the halo for atlantoaxial instability. The halo is excellent for atlantoaxial instability, and it is suitable for younger populations or children, and not recommended for old or geriatric population because it has many negative effects. And even as they call it for older age, it is a sentence of death. And regarding for how long, you of course start by 8 weeks, or even you can extend it for a while, and it's according to the pathology. According to the pathology. If you have fracture and you want it to heal, it may take 2-3 months for that. Then you can start immobilization and removing the collar or something like this. But if the pathology, of course, you need to be sure that you get rid of the pathology before allowing the patient to resume the motion and the activity and so on. Also, for atlantoaxial instability, the normal collar, cervical collar, is not recommended because it increases the motion at C1, C2, and COC1. So it is either halo or something like Minerva collar or something like this. I hope that we answered your question, Dr. Abdurrahman. For C1, C2, it is, thanks for the God, it is not really a very common surgery that everyday case. No, it is not everyday case. So it needs some knowledge and some importance of assessing the preoperative radiology for avoiding hitting the vertebral artery. It's commonly during the dissection over the arch of C1, posterior arch of C1, you don't go more than 1.5 centimeter from the midline. Afterward, you can have the vertebral artery in the field. Also, I do believe it is important to keep it like blunt section by peanut. Don't go with sharp object or even electrocautery in such a dissection, because you can hit the vertebral artery. So dealing with this area, also you can have some bleeding from the venous plexuses at C1, C2, So you need to have some hemostatic agents like Surgicel or Flucil if available. And of course, the bipolar electrocautery is very helpful. And some colleagues used to even cut the C2 nerve in order to properly visualize the lateral mass of C1. I did it once, and I have no problem with the patient regarding the suboccipital pain or something like this. So it is also not a big deal to cut the C2 nerve to properly manage the bleeding and expose the lateral mass of C1. It is always difficult to do the Magarel screw in patients with short neck or even in the patients with kyphosis because of the trajectory. You need to go from at the level around the C6, C7. So patient selection is also important to do either the Magarel screw or Harms and Gold technique. I will call what is going on with him.
Okay, sir. Thank you so much.
الحمد لله على السلامة يا دكتور علي. اتفضل يا
Alex
بيه.
with us, yes.
I'm sorry for this.
ما فيش مشكلة يا فندم، بتحصل على طول، ما فيش مشكلة خالص.
احنا كنا وقفنا عند كنا بنتكلم على الجويل هارمز تكنيك. بيبقى في تشيك ليست. Always we have a checklist before doing this atlantoaxial stability using the Harms technique. We're looking at reducibility and alignment. This is very mandatory and important. As we said, with Harms technique, you can rely on operative reduction. Also, you check the vertebral artery anomalies at the CT scan, and if you might need CT angiography, and the bone morphology as well, if you have local bone destruction or erosions or whatever. This is pre-operative. Operative, you have to check quite important point, because you have an atlantoaxial instability, you might need fiber optic intubations. Sometimes after positioning in the prone positions, you have to check that the reducibility is partially or fully reduced during the positioning observation before opening the wound. And also the operative alignment. I mean, the alignment of C1 in relation to C2 during the operations itself. And then you might need decompression in some cases. And before closing, you have to be sure that you release the neck and they do some core decompression, because sometimes we do neck flexion in order to have a good field, but you have to be sure that you reduce this neck flexion and do some screw compression to have an optimum position during the procedures. And finally, the post-operative image. This is a very important checklist you have to know. C1 screw placement is very important, because you have to know that the main issue with C1 screw is the C1 screw is not that difficult, but what makes it difficult is the the venous plexus around the C2 nerve root. The C2 nerve root is surrounded by very rich plexus. If you enter this, you might go into trouble. Sometimes we need to violate this C2, what we call C2 neurotomy, because it will be easier to cut the C2 with the venous plexus around in order to have a very good vision to the facet joint to do fusions and to do a reduction if you need it. And sometimes we need to put cage into this facet. So in this case, you need to do a C2 neurotomy. Is there a problem with C2 neurotomy? In most cases, there is no. Sometimes there is some residual paresthesia at the occiput that can last us for some weeks, and patient get used to it. So C2 neurotomy might be an might be an important step as these procedures to facilitate the C1 screwing. C1 screwing also is very, we have the entry of C1 is here, because we have actually 3 entry for C1 screw. This is the normal entry below the arch of C1. Sometimes we can do it posterior arch, just to do a hole at the posterior arch and make the screw purchase directly at the arch. But in this situation, you have to be sure that the vertebral artery is away from your screw trajectory, because as you see in here at the middle pictures, the vertebral artery is just above the arch. So it's important to be sure that you are away from the arch of C1. Sometimes you do just a notch around from the arch of C1 just to facilitate the entry of C1 screw. So these are the 3 entry points, but the main trajectory is guided by the anterior arch of C1. So you should have a C-arm and make your screw trajectory directed to the anterior arch of C1 in order to have a safe screw for the atlas. The C2 screwing is much easier and much riskier, because with C2 you have the vertebral artery just below your trajectory. So it's easy simply because you dissect the pedicle, the superior surface and the medial surface of the pedicle during the procedures. So you see where you are going. In many of cases, we do this without CR. And the length could be from 18 to 26 millimeter screw. And because you see the superior surface and medial surface of the pedicle, you can do it safely, but you have to know that the vertebral artery is just below and just lateral to your screw. So you have to make your screw trajectory as high as can and as medial as can, because you are safe from high and from medial, because you see the superior surface and the medial surface of the pedicle. So be high as you can and medial as you can. And in this case, you avoid the vertebral artery injury. Again, you can use the C2 pedicle screw with this trajectory, about 40-degree angulations, or the C2 bars, which is more or less 10-degree medial inclination. So you either use both. C2 pedicle screw is much stronger than the bars, but the bar screw is okay. If you have a problem with the high-riding vertebral artery, what you do is just to do a laminar screw. The laminar screw is very mechanically sound. It is equal to the pedicular screw of C2. You can insert a screw up to 32 millimeters, and you can insert unilateral. If you do one screw pedicle, you can do the other side's laminar screw, or you can use it bilateral. But in case using bilateral laminar screw, you have to use one caudal and one rostral to each other, and the entry point is just the junction between the base of the spinous process and the lamina, with one screw caudal, one screw rostral, to avoid going in the same trajectory. And every time you have to know that the vertebral artery is just below the bars or the pedicle screw, and you have to be aware of this and use any of the other options. The other options is to laminar screw, and if you don't aware about laminar screw, you can add to unilateral fixation posterior wiring just to make a 2-point of fixation. About C2 screw, C2 screw is very mechanically sound, and it looks like this as images, and it is mechanically equal to the pedicular screw. This is the another choice for C2 fixation. It's not common. The anterior fixation with the transodontal screw is very the most important anterior and the most commonly used anterior technique. And in order to use this, you should have an intact transverse band of the cruciate ligament. If you have intact cruciate band, then you preserve the motion by doing anterior screw. But if the cruciate ligament is ruptured, so you have to use posterior fixation. The other anterior option is the anterior transarticular screw. It's very rarely used. And the anterior atlantoaxial plate, again, is very rarely used. If we go to another entity, the trauma of the atlantoaxial segment, there is a lot of items, the C1 arch fractures, atlantoaxial instability itself, rotatory subluxation, atlantoaxial rotatory fixations, odontoid fractures, and hangman fractures. This is the AO spine classification of upper cervical fractures. As it is not very famous, so we'll use the old one, the Jefferson fractures, which is the C1 arch fractures. If it can be at multiple points, single, 2, 3, or even 4 points. But the important issue, if you have a lateral displacement of C1 lateral mass in relation to C2 lateral mass, more than 7 millimeter distance, now the transverse band of the cruciate ligament is ruptures, and this is unstable fractures. But if the lateral displacement is less than 7 millimeter, so the cruciate ligament is okay and the segment is stable. So this is the indication for surgery, the instability. The other C1 fracture classification, the Gweiler classifications. And if you look at these 5 images, you can see that type 1, type 2, and type 5, these are stable fractures and treated conservatively. But type 4, if you have distraction of the lateral mass here with displacement, now you need to do surgery. And type 3, you have 2 types of type 3. Type 3A with intact ligament, no displacement, stable, conservative. Type 3B with lateral displacement more than 7 millimeters, unstable segments need surgery. And this is how the things go with type 1, 2, 5 stable. And type 3, if you have more than 7 millimeter, you need to do surgery. Less, you have to do it conservatively. How about surgery of C1 fractures? If you have a young patient with no comminution zone in the lateral mass area, and you have surgical expertise with C1 osteosynthesis, now you use C1 osteosynthesis. But if you are not familiar with C1 osteosynthesis, you do a C1 fusion. And as I said, type 4 is treated conservatively if there is no displacement, or treated surgically if there is destruction with displacement of the lateral mass of C1. This is the C1 fractures treatment. If you use the posterior fusions like Galley or Goyle fusions, now you're losing 50% of the rotations. But if you're losing C1 osteosynthesis, now you preserve motion of half motion of the neck and avoid implant removal, and also avoid bone graft from the iliac crest. So osteosynthesis is very good options for the arch of C1 fractures. How about the atlantoaxial stability? We are all familiar about what we see in these pictures, the anterior atlantoaxial subluxation or instability. If the anterior atlantodental space is more than 3 millimeter in adult or 5 millimeter in children, this represents instability, and this represents incompetence of the cruciate ligaments. But there is another term called the central or axial instability. This term is popularized by Professor Gould, who have classified the instability into 3 types. Type 1, anterior subluxation. Type 2, posterior subluxations that could be associated with some rotation of the facets from either other side. So one side is anterior, one side is posterior. So this is posterior translocation. This is type 2. Type 3, there is no abnormality in the bone and only can be detected intraoperatively. You call it type 3. And this type 2 and type 3 is not famous and maybe not be accepted by a lot of surgeons, but he popularized this technique for the management of Chiari malformation with syrinx. And he advocates that there is an operative instability. How about the atlantoaxial rotatory subluxation or fixation? The term subluxation or fixation is coming from because normally there is 50% motion coming from the atlantoaxial segment. So normally there is rotation of atlantoaxial joint. So how to differentiate between normal atlantoaxial rotation and abnormal? The abnormal rotation is fixed, but the normal is mobile. So if you do a dynamic CT scan looking for the right, looking for the left, and do CT scan, you can see reduction. Now it is subluxation. This is normal. But if it is fixed, now it is abnormal and need management. It is subclassified into 4 types. Type 1, which is most common, there is intact ligament, no significant displacement, and can be treated conservatively in the majority of cases. But type 2, there is ruptured ligament and translation less than 5 millimeter, rotation more than 35 degree. If it is below 2 weeks, you can treat conservatively. But if it is more than 2 to 4 weeks, now the response will be poor for conservative treatment, and we need surgery. And surgery in this case usually posterior fusions. Type 3, more than 5 millimeter dislocation, more than 40 degree rotations. The alar and transverse band are ruptures, so it is unstable. Whatever it is acute or chronic, it managed with surgery. Type 3 was very, very rare. There is posterior translation of the atlas, and this is treated by surgical technique again. The chronicity of rotation could be identified on this because with chronic rotation, the facet become abnormal and the inclination increase. So this grading explains how the chronicity of the facet osteoarthritis and the inclination increase with time and make conservative treatment and even surgical treatment sometimes difficult. About the entity of dense fractures, this is 3 subtypes. The type 1, which is the tip of the dentate fracture, was very rare and stable. Type 2 is the most common one and usually comes through the synchondrosis between the dens and the body of C2. And because of the blood supply is peculiar at the synchondrosis because it is watershed area, the non-union vary from 20 to 90% in the literatures. So it's important to differentiate this type from other types. And this type, if associated with ruptured transverse ligament, then we have to treat it posteriorly. But if it have intact cruciate ligament, now a transdental screw is the method of choice for treating this. And type 3, which goes through the body of C2 with a wide surface area and extensive blood supply, respond well for conservative treatment. This is how type 2 and type 1 and type 3 can be evident at the X-ray. And again, type 2, which is the most common type, can become in a very devastating as these images here. But usually it comes with these images on the right. And because of the peculiar blood supply, we have to treat it surgically. About traumatic spondylolisthesis of C2, or what we call hangman fractures. This is a bilateral, rarely symmetrical fracture of the neural arch of the axis that can be including the pedicles, the bar, lamina facet, posterior vertebral body. And this type of traumatic spondylolisthesis, we have 2 types. The judicial type, or what we call the true hangman that used for the المحاكم الجنائية. It is an hyperextension associated with distraction, and these distractions cause ischemia of the brainstem and the medulla, resulting into sudden death. But the traumatic type is associated with, this is the judicial type, so there is hyperextension and distraction. This distraction causes medullary ischemia and sudden death. So the other type, which is traumatic one, is caused by extension with axial loading. This axial loading resulting in opening the canal, and in the majority of cases they became intact. And however, there might be sudden death at the scene of trauma. How to measure the displacement? By the angulation and by displacement. If you have more than 50% displacement, and the posterior disc space is more than the disc below, now the segment is unstable and needs surgery. And if less, now it is stable and could be treated with conservative treatment. About the grading, we have 3 grades. Grade 1, there is minimal subluxations and no displacement, and this is treated with a collar. Type 2, we have 3 types of type 2. Type 2 in extension, in flexion, and in neutral spondylolisthesis. The disc space is interrupted and the segment is displayed, so it is abnormally located and unstable by disc disruption, so it is treated with posterior fusions. Type 3, this is the very rare type. Usually there is anterior translations in flexed position, and the facets are locked. So there is severe dislocation and facet locking. That's why this type of trauma usually need open reduction and posterior fixation. This is an example of type 1. No significant displacement, no disc disruptions, so it can manage be with conservative treatment. There is other options for hangman fracture like C2-3 plating or posterior transpedicular screw, or different options as we've seen here. This is the anterior plating, and this is what we call the Jodet fracture, which is a transpedicular screw fixations. And this is the transpedicular of Jodet, which is old technique down to 1962. And in these images, we can see the various options that can be used for treating hangman fractures, like anterior plating, Jodet screw, C2-3 posterior fixation, C1, C3 fixation, or even anterior and posterior technique. Now we finished all the theoretical section, and now we're moving to some examples, and we'll go fast with this. This is a case of Down syndrome, a young child, 3 years old. You can see very severe displacement and the cord signals here. And we managed to do this with the Goyle-Harms technique. It was a very rough and very tough case. And you can see in the middle picture here how the screw is very close to the vertebral artery in this very young child. It was a very challenging case. Another case of dense fracture. If you look at the MRI, you can see the prevertebral hematoma and the type 2 dense fractures. And in the middle, you can see the high-riding vertebral artery. In this, you look at the sagittal images, you can see the normal vertebral artery on the left and the abnormally vertebral artery on the right. In this case, you cannot put a pedicular or bars screw, but we use the laminar screw as we see here. One pedicle, the other one is laminar screw. How about this is a case that had rotatory atlantoaxial fixation treated with wiring before, then the wire is broken and graft is resorbed. So we managed to do it. Usually we use these cases usually they are young children, 7 years or things like that. So we use Holter traction to reduce the deformity prior to doing surgery. And after Holter traction for maybe 1 or 2 days, the reduction, the deformity is reduced, and we take him to surgery, and we use the Goyle-Harms technique. Usually for lateral mass, we use the bicortical, as you see here, the bicortical for the lateral mass. Another case of atlantoaxial instability, severe cord and severe displacement, irreducible. There is assimilation of C1 and severe cord compression, traction didn't work. But in the majority of these cases with anesthesia and muscle relaxation, you get some very important or significant reduction of the deformity. So we managed to do an occipitocervical fixation in this case. And because we wrote a lot of strain on this, postoperative is okay. As you see, MRI postoperative is okay. CT is very nice in comparison to preoperative CT scans. And because we put a lot of strain on this, so the system broken, and we revised this with a Y-shape system that's commonly used nowadays. Another case of Down, you can see the severe cord compression and cord signals and the severe displacement. And also we manage this with the Goyle-Harms technique. You can see the operative fluoro after reduction and the insertion of the screw. we use an iliac crest graft. But because the healing is very poor in this kind of patient, you have to do Philadelphia collar for a long time, because these children have to be observed for a long time, because sometimes they didn't feel and require occipitocervical fusion. About this case, this is a case of severe atlantoaxial instability, and you can see the deformity through the CT scan. And we diagnose it as an osteodontedium simply because this has an anterior spina bifida and a posterior spina bifida. So because there is no history of trauma and the associated anomalies, we tend to diagnose it as osteodontedium, and this is the post-operative images in this patient. Another example of rotatory atlantoaxial fixation. As we said, this is on the left side, the preoperative rotation, and on the right side, after traction, we used Holter traction to reduce this, and then we do operative fixation and iliac crest graft. How about another example of this is a case of aneurysmal bone cyst. You can see the excision of the anticurettage of the aneurysmal bone cyst and fixation of C1 to C3, and then patient received radiotherapy. This is a case of type 2 disc fracture, reducible, but there is high riding vertebral artery on one side here. This was a mistake that we didn't notice, or we tried to do it. Anyhow, we injured the vertebral artery during the operation, but because you see a follow-up 1 year, so the patient bypassed this problem, and you can see the reduction and the C1 lateral mass and the C2 screw going through the vertebral artery. And this is another case of chronic atlantoaxial instability. This is another problem as well. You can see the severe displacement. Actually, it was irreducible before surgery, and you can see the chronicity from the facet changes, and also there is a vertebral artery problem here. That's why during surgery, as I said, with muscle relaxation, the majority of these cases get reduced, and we managed to do operative, but during surgery, again, we hit the vertebral artery. And as you see here in these images, there is one vertebral artery is violated, and there is one of the lateral mass screw is in abnormal. So we revised the C1 lateral mass, not the C2. So the take-home messages, actually, I just wanted to show you this case before the messages. This is a case of atlantoaxial instability. You can see the prevertebral shadow here, and you can see the MRI. There is prevertebral mass, and there is enhancement. And you can look at the CT scan. There is erosion of the around the C1. So we diagnose this as infection, and we managed to do this by occipito C2 fusion. I'll go back to the take-home. In patient with atlantoaxial instability, the surgical procedure should be tailored to each case. Proper procedure selection and indication are mandatory for safety and efficacy of the management. Meticulous technique and anatomical knowledge are mandatory also. Muscle-less CT scan is an essential tool to exclude C2 anomalous vertebral artery, plus or minus angiography. Thank you very much. And sorry for the interruption.
Thank you, Professor Ali Abulmadawi, for this nice presentation. Professor Ali, Professor of Neurosurgery at Suez Canal University. He was the past chair of the Egyptian Spine Association. And Dr. Ali currently is the chief editor of the Egyptian Spine Association for Advanced Spine Journal. And he was one of the pioneers who published a lot of research regarding C1, C2 pathology. And by this, we reached the end. Sorry that Professor Hassan Salhin didn't be able to attend. Maybe have some unforeseen or emergency problem. I couldn't reach him through the telephone. Sorry for that. But over the last 2 hours, 40 minutes, we had nice talks. It covers the spinal canal stenosis, the thoracolumbar fracture, how to diagnose spinal infection, and finally, C1, C2 pathology, and how to manage. I'd like to thank Professor Dr. Muhammad Al-Ashhab, the Dean of Panha University and Professor of Orthopedics at Panha University, and the Egyptian Orthopedic Association board member, for his continuous support for the young and old generations in orthopedics, because I believe the doctors born to be a student all over the days, all over the years. We are learning from each other, and today I learned from my friends and my colleagues, and every day I learn from Dr. Muhammad Al-Ashhab how to be humble, how to be patient, how to be have the enthusiasm and the fight for spreading and exchanging the knowledge. We have right now 78 attendees. Over the webinar, we had 120. I know, Professor Muhammad, this is not your figures in orthopedics, but for the spine, for us, it is very nice.
I know, sir.
And I'd like to thank the whole attendees for their patience and their presence. And thank you, Dr. Ashhab. Would you like to add something?
Yes, please. Thank you so much. Thank you so much, my dear friend and my dear brother, Professor Muhammad Fawzi Khattabi, Shamsi University, and the president of the Egyptian Spine Association, for his great effort in the preparation of such a very fruitful scientific day, discussing all the topics and the aspects of spine pathology, including trauma and diseases. I think we have discussed all the topics regarding the spine pathology. Also, many thanks, sir, to our eminent guest speakers from Germany, from Professor Christoph Saipi from Germany, also Professor Hamdan Abdurrahman from India, Professor Abhainini, and also from Egypt, Professor Abu Madawi, Professor Ali Abu Madawi. Thank you so much, sir, for being with us. And I hope to see you, all of you, again in another specialty day. The next specialty day after 1 month will be discussing the fracture of the pelvis and the pelvic pathology. And then we will go with the, of course, pelvis and acetabulum. And we will go then with the hip, the knee, the foot and ankle, the shoulder, the elbow, the wrist and hand, and finally the oncology and pediatric and deformity. So many thanks for all of you. دكتور محمد بيه، جزاكم الله كل خير على مجهود حضرتك يا فندم. دكتور علي بيه وكل اساتذتنا الافاضل، يعني
شكرا جزيلا.
شرفتونا يا فندم ونورتونا، ربنا يبارك فيكم جميعا.
شكرا جزيلا دكتور محمد.
شكرا
جزيلا اساتذتنا الافاضل، شكرا جزيلا يا فندم.
كل
عام وحضراتكم بالف خير، وان شاء الله رمضان كريم على حضراتكم جميعا يا فندم ان شاء الله. Thank you so much, sir. Thank you so much. تصبحوا على الف خير يا فندم. سلام ورحمه الله وبركاته.